evening, everyone, and thank you once again for joining this edition of AMR Masterclass, the detailed sessions on AST reporting that we are hosting with in association with American Society for Microbiology and Dr. Sumit Rai. At the outset, I would like to welcome you all to this session which were clinical footnotes in AST reports. And we have with us today Dr. Reba ma'am, who is renowned faculty in this in the field of AMR and others. I'll take her introduction, and Dr. Sumit Rai. So let me welcome both the faculties once again, and thank you so much for your time in these sessions. Thank you, audience, for consistently joining all the sessions, viewing the recordings, and we really appreciate all the questions. So we've got few questions already with us even before the session has started. And yes, like all the sessions, we see, by the end of the session, we have a whole lot of questions, and we also try to answer these, most of these during the session. And for whatever is remaining, we have our faculties answered this. So you would have received the question and answers for the last sessions as well. So now I'll quickly introduce, though both of these faculties need no introduction, but as a formal start to this session, I will quickly introduce Reba ma'am and Dr. Sumit. So Dr. Reba Kanungo is Dean Research and Head of Clinical Microbiology at Pondicherry Institute of Medical Sciences, Pondicherry. You can see the credentials, on around laboratory support, faculty as microbiology in Pondicherry, and the international assignments that she's undertaken right from Nepal to US and other countries. So she's worked extensively in the field of microbiology, and all of us, I think, recognize and value her contributions. Thank you so much, ma'am, for joining this session, and your inputs in the previous sessions as well. Dr. Sumit, again, professor in HOD, Department of Clinical Microbiology, AIMS Vijayawada. He's formal additional professor, Department of Clinical Microbiology and Infectious Diseases. Is moved from this part of the country, that is Delhi, Noida, to Vijayawada. He's got 18 plus years of experience in microbiology. He's got numerous publications, book chapters to his credit. You can see all the credentials which are there, and I'm sure by are quite well versed with the expertise that he carries in this on this subject. So I'll welcome you, Dr. Sumit sir, as well to the session. And without taking more time, I'll hand it over to Dr. Reba. Before Dr. Reba takes the session, I'll request you, the audience, to keep, as always, keep posting comments, questions, any feedback that you have on these sessions in the chat box. And let me make sure we read and try to respond to all of these comments and questions that are posted. So, thank you for your participation, and over to Dr. Reba. Welcome, ma'am.
Thank you. Am I audible?
Yes, ma'am.
Yeah, thank you, Dr. Neha, for that introduction. And it has been a pleasure to be associated with BD on behalf of the American Society for Microbiology, and Dr. Sumit Rai, who's powerhouse of knowledge on AMR. I have been following, or rather, following the lectures and giving short introductions. My role here is just to open the topic so that Dr. Sumit takes over and elaborates on the details of the AMR. Through the past couple of sessions, we have been introduced to the antibiotic susceptibility, the importance, the facts that go into it. And now we've come to the third session where having done the antimicrobial resistance testing and, how do we report it? And it's just not the report that goes in as, a particular organism, let's say Escherichia coli isolated in culture, sensitive to so-and-so. The report does not end there. So what is this clinical footnotes and what importance does it have in a microbiology, culture report? So before I start, I would like to, go through this disclaimer that this presentation does not endorse any product, company, or laboratory system, neither any organization or academic society, and there is no conflict of interest. So going back to the main crux of the problem, what are these clinical footnotes? What is the importance and why do we need to add clinical? After all, we are microbiologists. Why should we be adding, extra information or footnotes on the report? Now, basically, the footnotes are nothing but post-analytic comments. We know that our process goes through pre-analytic, starting from patient sample collection, patient details, history, etc., and the history of infection, plus the relevant sample. Then we have the analytic, which is the main thing, that the main process which occurs in the laboratory, and our whole technique, which is absolutely, it's absolutely unknown to the clinical side, clinicians as to how the specimen is processed and what comes out of it. Then finally comes the post-analytic stage, where whatever information we have gathered through our process gets transferred to the clinician so that they can manage the patient or they can treat the patient. So this is very crucial as to how we convey our results to the clinician and what information, extra information that we need to add on to these reports for them. So why do we need these extra information? We must be aware that, or we must ensure that the report that goes to the clinician is not just a report. It is meant to treat the patient. It's not just a piece of paper which conveys some kind of a message, but it is a directive for the clinician on how to treat the patient based on the information that is provided from the laboratory. So how do we do this? We should correlate the laboratory findings with the clinical picture. So in other words, a laboratory report should always be correlated with the clinical picture. Just to give you a small example, I'm sure Dr. Sumit is going to come out with all the actual evidence that he has been collecting and the information. If a patient comes in where we do not know what the clinical signs and symptoms are, but we just get a urine sample for culture, the clinician writes urine for culture and sensitivity, and we get a plethora of organisms. So how do we interpret it? Is the patient really having an UTI, or it's just a routine, by the whims and fancies of some clinician, they want to do a culture? So therefore, we need to know that what is the status of the patient, or for that matter, a blood culture. Is the patient febrile? Does the patient have any signs and symptoms of infection? So we need to correlate with the clinical picture for sending out an appropriate, relevant report. So as we know, microbiology process encompasses a broad range of testing methodologies, and it is very complex in terms of the organisms which are isolated, sometimes organisms which are not known to the clinicians. We isolate and report them, and they'll be jumping around saying, oh, what is this? Then the methods used to isolate and identify them, we are very much aware of it. What are the various methods we use? And finally, the AST readings that we take are highly complex. It is not just a simple zone diameter or MIC that we take and then we send it across without any, meaning to it. So therefore, the report that goes out is highly technical and would make no sense to the treating physician if it just goes out like that without trying to interpret and make it simple for the clinician to understand. Now we know that the test and treatment cycle, where we have the sample, the analysis, the antibiotics, then the test that we do, then the treatment that the patient receives, and the monitoring. So therefore, this whole personalized treatment cycle is important. It is personalized. That means it's not like one answer fits all or one glove fits all. It is personalized, it is individualized for every patient. Therefore, we need to give information for that particular patient, and it is necessary to provide these post-analytical comments, which are known as clinical footnotes. The results must be communicated back to a clinician in a way that he or she can interpret and act appropriately. And therefore, we call this as the personalized antibiotic therapy. How is it personalized? Because a sample is collected from patient A. We isolate the organism from patient A. We report the AST for patient A. And the patient's clinician, the patient A's clinician chooses the appropriate antibiotic and predicted to be effective against that patient's infection. So this is personalized, very, very personalized, a kind of a report. And therefore, that leads to a rationalizing antibiotic therapy, which is compatible with clinical signs and symptoms. So this rationalization is not just arbitrary, it has to be compatible with clinical signs and symptoms. So optimal antibiotic, the personalized antibiotic therapy is basically an optimal antibiotic for each individual patient that is based on a number of clinical and laboratory features like the organism, the MIC, patient-specific factors like weight, immune status, etc., the site of infection, desired method of dosing, and patient convenience, whether it's oral versus intravenous, and drug interactions. And finally, of course, which is important, is the cost. All these things must be kept in mind by the laboratory personnel also when they are sending out reports. So we have to keep in mind, does our report convey susceptible with the standard dosing, or is it susceptible with increased exposure? So susceptible, dose dependent. So is it that, in other words, what we report it as I, this is the SIR form. So just when we write intermediate, are we explaining what this intermediate means to the clinician? Because the clinician is not aware of what, for many years, the intermediate used to be clubbed with the resistance. So now the fact is that intermediate has its own importance. So what does it convey? Now, when we write susceptible with standard dosing, we mean that the dose is the amount of agent given to the patient for a susceptible organism. But when we talk about the susceptible with increased exposure, that includes a dose, mode of administration, and both general pharmacokinetics and pharmacodynamics at the site of the infection. So it is not interchangeable. The exposure is not interchangeable with dose, and neither is dose interchangeable with exposure. Exposure is when we mention that the antibiotic is intermediate, the organism is intermediately susceptible. So in which case, if there is a range between the susceptible and the resistance, then we could increase the dosage by either decreasing the time interval or increasing the amount of antibiotics per kg of body weight, etc. So that way we can hope to combat the organism with an increased exposure. So this is the SDD, or the susceptible dose dependent. Then we come to the resistance. Now, resistance actually means that the organism is per se is resistant. It has acquired the resistance through several mechanisms. So therefore, sometime it may have been sensitive earlier, but now it has become resistant. So this particular organism that has been isolated from the patient is resistant, and therefore we cannot increase the dose, or we cannot, decrease the time. So therefore, the patient cannot be treated with this particular antibiotic. This particular patient cannot be treated with this antibiotic. So therefore, this is again personalized to that particular patient. Then next we come to non-susceptible. Now, non-susceptible again here means that this organism, whoever be the patient, whatever be the dose, the organism is not going to be susceptible because it is inherently resistant to this particular antibiotic. And we know several examples of this, especially with organisms like Acinetobacter, Pseudomonas, Enterococcus faecalis, which are inherently resistant to several classes of antibiotics. So therefore, when we report zone diameters and MIC, it should not be reported without an interpretative category or interpretative criteria. This is very, very important, that there should be an interpretation from the laboratory guiding the clinician into appropriate treatment. Some examples of footnotes to aid treatment. Dr. Sumit is definitely going to go very much into the details and explain to us what exactly must go into the reports in terms of clinical footnotes. But just to give you a few very simple examples, like daptomycin treatment for pneumonia, we have tested the organism again isolated from either a case of pneumonia, either from sputum or bronchoalveolar lavage or from the blood, and we have tested for daptomycin. But we know that, as a panel, it has gone in as tested for daptomycin. But we should tell them that daptomycin is not the treatment should not be treated in case of patient having pneumonia. Then therapy-related note. Now, if rifampicin is in your panel and you have done rifampicin susceptibility, and then you send out the report, but there should be a footnote that rifampicin should not be used alone for therapy. Now, your report should also have avenues for de-escalation. It should have contain antibiotic, the susceptibility pattern should be in such a way that if the clinician wants to de-escalate, he or she can choose from your report or from the panel of susceptibility. And also, it is important to note intrinsic resistant comments to ensure that proper notification is included on the reports. This is again very, very crucial. Intrinsic resistance. Your panel might have, Pseudomonas susceptible to, let's say, penicillin, but your report should ensure that Pseudomonas is inherently resistant to or intrinsically resistant to some of these antibiotics, and that list must be there. So these are some important footnotes. And these clinical footnotes make a difference in patient care, definitely, in antibiotic stewardship, very much so, and also for medical cost management. So these are some of the key points that must go into a microbiology report when we send it across to our clinicians. So thank you very much. And I think this was just a small little, what should I say, a little pointer towards the lectures the discussion that is going to follow with Dr. Sumit. And so I will stop here, and thanks for your patient hearing. Before I, hand over the stage to Dr. Sumit, I would just like to mention here that there was a question which I kind of missed out in the file that had come in regarding the importance of gram stain in CSF smear. Now, let me tell you that gram stain is one of the first rapid methods, simple, cost-effective rapid methods of detecting an infection in a case of acute pyogenic meningitis, or for that matter, meningitis of any infectious origin, mainly because it is the simple thing that you take a drop of CSF and you do a smear, and can be done as a bedside test, very cost effective, and it has a very high positive predictive value. If you get a smear, let's say a pneumococcal meningitis, acute pyogenic meningitis due to Streptococcus pneumoniae, and in the gram stain shows you gram-positive diplococci, sheets of gram-positive diplococci, there is nothing else that can help you to clinch the diagnosis, but the very fact that this, and then it is useful in treatment, as well as you can even do a direct susceptibility testing with the CSF sample, before you can, of course, to be modified later on by the proper method. But again, CSF smear, or you see a gram-negative diplococci with plenty of polymorphs, or you do not see any organisms, but you see plenty of lymphocytes. So these findings will help you to come to a provisional diagnosis of acute meningitis case. So yes, a gram stain does have an important role to play. It can be done at any time of the day as an emergency sample testing, and a very quick method and very cost effective. So I hope it answers the questions put up by one of the participants as to the importance of doing a gram stain in CSF. It is important and it should be done. And in fact, it can be done in almost all labs. You don't have to depend on any high-tech instrument to do this test. So thank you. I hope it answers your question.
Reba ma'am, for this brief but really enriching introduction to the session that will be elaborated by Dr. Sumitra sir, and also, your insights on the question. You remembered to answer it in this session. So much appreciate. If the audience has any follow-up questions, yes, all of you know where to put it. So you have access to chat box, and we will reach you there. So thank you, Reba ma'am, and yes, we hope to see you towards the other end of this session during the Q&A. And yes, over to you, Sumit sir. Welcome, and yes, you can start the deliberations for the day.
Thank you so much to BD Diagnostics and ASM. Special thanks to Reva ma'am for the introduction. That was very, very enriching, and that has helped us to roll the ball. And she's been a huge guidance and a source of inspiration to all of us. So can you see my presentation right now? Because I'm controlling it from my end. So I just wanted to be sure that my presentation is visible.
Sir, it is visible to me, and I am sure we'll get messages from the audience in case it is not to them. Yeah.
Great.
Yes, sir, it's visible, sir. We can start, sir.
Right. So good afternoon to all the participants. And again, thanks to ASM, Reva ma'am, and BD for arranging this certificate course on AST reporting. We have already had one introduction session and two sessions before, how to make the panels and how to do selective reporting. This presentation would be a little bit, some parts will be overlapping, and many things, there are a lot of screenshots over here, which I've taken from my own reports and few interesting review articles that I came across. So, yeah. So as usual, the disclaimer I'd like to put up, this is in the first session, we received somewhere around 62 questions. In the second session, last session, I received somewhere around 112 questions were received. And like I keep on saying that I don't have the answers, but yes, these questions always, they help me to learn more. And, I'm always receptive to newer things, because that's how we move ahead. And like I keep on saying that we must always remain in the log phase of our learning, because the day we stop feeding our mind with new information, new thoughts, so new things to learn. So we'll go in the lag phase, like we'll go in the stationary phase. So I'll be displaying what we practice. It may not be the best things available, but we are somewhere in the between. We are not fully into automation right now. So, what I'm practicing or what our team is practicing right now, we can correlate with most of the people, because automation is not present with everybody. If there are any queries, or of course queries will be addressed to us. If there's anything wrong in the presentation or any mistakes are there, please inform me. And this got mainly a lot of screenshots are over here. And we'll have there'll be some components of selective reporting also will come in the clinical footnotes. So, like it is said that picture speaks 1,000 words. We've all heard this thing before, and we as children must have seen this picture many a times before. And you can see that this is a stork who's been invited by his friend And from this picture only, you can recall that this is a part of the Aesop's fables, where you get a moral of the story that do not play tricks on your friends unless you stand the same treatment for yourself. So basically, you know that what this picture looks like, and you know that what is the moral it's going to give you. But then what about this picture? I mean, this is, you have seen multiple times, but what about this picture? You can see that there's a man standing over here. He's probably measuring the height of a boy on this tree, and he puts a nail over here, and then probably over the season, over the winters, the trees probably grows in height. So is it the real story? But what I see over here is that, even in the next winters, in the next year also, they're wearing the same clothes. So, I mean, it could be anything. I mean, are they father and son? Did the boy shrink in size, or the tree has grown in height, or the tree has grown at a rate faster than the boy, or they are totally different trees? So, this picture can give you multiple messages. Similarly, an AST report speaks 1,000 words, which can confuse a clinician. Right? You might report 36 antimicrobials. Last session, we had discussed not to report 36 antimicrobials, just report which are selective few, which are specifically meant for that particular patient only. Do selective reporting. And other than that, also we need to have clinical footnotes, because even after selective reporting, this is the kind of messages that we get at times. Like somebody, this is the selective reporting that we have done. It is written over there very clearly that this is SR-AST, that selective reporting of the AST has been done as per CDC and CLSI M100 guidelines. Yet we were asked that what do these blank mean? We are not reporting cephazolin, cefotaxime, cefoxetine, ampicillin, piptazo. All are not being reported. So what does that mean? Resistant? So I replied, no, it does not mean resistant. It is selective reporting. It is mentioned over here, selective reporting. So despite putting up special words and everything, even then, just putting up the clinical footnotes also, many of the people don't read what is written over here. So we have to tell them specifically that this is selective reporting. That means these are susceptible, but we are not reporting it. But if it is required, if the patient is non-responsive to the other antibiotics, we will do a cascade reporting. And what we attempt to do is to do a personalized antibiotic reporting if we get the patient details. So the clinician also agreed that they will insist that all the history is given on the TRF, that's a test requisition form. So despite having this kind of reporting, and this is on our HMIS, that is on our hospital management information system, we are putting up for the urine cultures, we are putting up this thing. Despite that, we get these kind of messages. So the clinical footnotes in the AST report, are we simplifying the message, or we are just complicating it? Because limited information is necessary, and it has to be very crisp also. And what are the clinical footnotes? Ma'am has already given a very nice introduction, lucid introduction has been given. Why are they inserted, and when are they required? What are the advantages? What are the clinical footnotes that you need to insert in your reports? Will they complicate the report? How will it affect the practice of the clinician? Is there any framework, any guideline, or we need to design our own clinical footnotes? So fact is that we don't, except for certain known facts, the rest of the clinical footnotes we have to design on our own. And most of the facts, they are available on literature, they are available on CLSI guidelines, they are available on our textbooks also. Basic things like, for cultures, don't send specimens in formalin. That's a very basic thing. That's one of the sampleization criteria. So if you don't put a clinical footnote and interpretations of the AST report, you get all different kind of interpretations like this. And you just saw in the previous slide also that despite putting the footnotes also, there are a lot of issues that people don't read them, or you have to actually communicate with them. So communication, you can't get away with communication by just putting up the clinical footnote. You have to do that. And who will communicate? No matter how much automation you have in microbiology diagnostics, you just cannot replace a clinical microbiologist. It is a clinical microbiologist who will do the clinical reporting, who will do the clinical interpretation, who will follow up the patient with the clinician, talk to them, discuss the case, and then accordingly report the antibiotics, do not report the antibiotics, report selective antibiotics, do the therapeutic index reporting, or do the selective reporting. So all this, you just cannot replace a clinical microbiologist despite all the automation. So the way that histopathology can be done only by a pathologist. Similarly, AST reporting specifically, and I'm telling you regarding the technical committee 212 of ISO 15189, is specifically only one of the working groups is only dedicated for the clinical AST reporting only. Out of the 4 working groups of the entire lab services, there are 4 working groups in Technical Committee 212, which makes ISO 15189 guidelines. Out of those 4 working groups, all 3 are dedicated to all the 3 branches of biochemistry, pathology, and microbiology, but one working group is specifically dedicated only for AST reporting. So that's how important AST is. So that's why I'm repeating again and again that despite whatever automation you have, you cannot replace a clinical microbiologist. Now, what is the literature which is available? If you just Google these footnotes, as a search engine, I prefer more of Google rather than PubMed, because it gives me a wide variety of articles as compared to PubMed. Maybe I'm too bad at it. Maybe I need to learn more on that. But if I Google clinical footnotes in antimicrobial susceptibility testing reports, then these are 2 major articles which I get. This first article by Schreckenberger we have discussed already in my previous sessions. I'll just revise it for you in this session also. And the other very important and the most important and the main reference that I've got is from Dr. Deepashri and Dr. Purva and Dr. Sandhya. Very interesting article, and it's a review article primarily based on the blood culture reports that they are doing in JIPMER. Plus, I'll be citing a lot of examples of our own reports and the comment templates that we have made in our institute. So this was that report by this particular article by Schreckenberger, which I had discussed previously, that how to optimize the AST report. And they said that, after many discussions, they have to practice things like cascade reporting, selective reporting, MIC-based reporting, patient-specific factors such as, personalized antibiotic reporting based on weight, immune status, allergies, creatinine clearance, and all those things, site of infection, desired method of dosing, bolus dosing. So PK/PD things also have to be taken care of. So all these issues have to be addressed in your antibiotic reporting. And with this premise, they had shared you can call it a EQUAS kind of a thing, where they had sent a sample of a group B streptococcus from a pregnant female. They sent it to around 15 labs. Only 3 reported that we will not test anything. It is group B streptococcus. It is just a colonizer, and in this case, you can give the patient penicillin unless the patient is allergic to penicillin group of drugs. Then only we'll release the other reports. So that is the kind of comments that should go in these kind of reports. Like some labs have reported all the antibiotics, and some labs have not reported anything at all. So in the previous session, I had mentioned this particular slide about selective reporting also, and what should be the clinical footnotes that should go with these kind of reports. So there are certain insights from other references also, like this, for example, this clinical microbiology newsletter that was pretty old, almost like 20 years old now. They have added the value-added reporting. That's what is the value that you're adding to your clinical microbiology reporting based on computer-based textual reports and comments as an aid to communicating appropriate utilization of the results. So like Madam has said, that you have reporting, you're doing a good job, you're doing reporting, you've tested the right antibiotic in the right against the right bug in the right specific site. But then how are you reporting it? What are you reporting? What is the interpretation? What value are you adding to those 10, 15 antimicrobials that you are sending, or selective reporting that you're doing? What is the value of you adding? So basically this article discusses about all different kind of messages or clinical footnotes that can be added to your clinical microbiology reporting or on your AST report. Like, for example, I'm sure that many of you would be have seen these kind of reports, or maybe practicing it also. Like, for example, this is a beta-lactamase positive organism, should be considered resistant to penicillin, ampicillin, amoxicillin, and related compounds. Or like, say, you can say that this is Enterococcus fecalis. It's most of them are susceptible to ampicillin or nitrofurantoin. This is a VRE, and we are holding, and we'll like do a cascade reporting for linezolid or quinapristine, dalfapristine. MRSA is resistant to all the beta-lactam drugs. So, like, for example, repeat isolates. So many times we get repeat specimens, so sent within 5 days or in 3 days. So we have to send the report that repeat testing will be performed only after consultation with the microbiology laboratory. Then all things like colonization with group B streptococcus, just discussed in the previous slide also, whether we are having a normal respiratory flora is there, and 2 blood cultures should be sent. So these are the basic you can say the clinical footnotes that are suggested by this particular article. This is also interesting article, and this can be, these can be incorporated in your clinical footnotes in your clinical microbiology reporting. This was a very interesting poster presented by Dr. Aksha, and just briefly we discussed about this poster also, which she had addressed the problems which are related to the microbiology identification and AST reports in India. Like only the isolate name with the SINR is given. What is the meaning of that? We don't know. MIC is not given. Automation is not there. And authorization is being given by non-microbiologists and lab technicians and pathologists who are not trained in clinical microbiology reporting and AST. So these are the major issues which are addressed, and try to circumvent those things by taking initiatives like selective reporting, site and isolate specific comments, sample adequacy, like, what are the site of sample is being adequately collected or not, what is the quality of the sample, collection of sample, recommended antibiotics. So double checking your reports, repeat sampling when required. So all those things. So very interesting poster this was, and she had also recommended that what are a few interpretive comments can be put up in your AST report. Like, for example, sample collection site and details are not mentioned to elicit the pathogenic significance. So like you just send a sample without mentioning the what is the site. The syndrome is not mentioned, site is not mentioned, any previous antibiotics are given, is not mentioned. So there is no, we don't know to elicit the pathogenic significance, whether it's a true pathogen or not. And if there are like, if we're getting a heavy mixture of gram negatives in the urine, so that tells you that it's not a clean catchment stream urine sample. So for the clean catchment stream urine samples also, you can send a clinical comment. Hand hygiene comments we've been putting up on a routine basis. This is the comment for intrinsic resistances. Then like if you get a staph aureus, like a descending infection in the urine, like staph aureus you're getting in the urine, it's a descending infection. So most likely it's an infection of the renal parenchyma. So you have to look for pathology in the upper urinary tract also. So these are the kind of interesting comments that this poster had suggested. And the main center of this particular presentation would be this particular review article by Dr. Deepa Sri and Dr. Sandhya and Dr. Purva. And I think that this is a must-read review for all the postgraduates and senior residents. So I'll be just talking about the tables which they have inserted, and because most of the comments suggested by the review are specific for automated blood cultures. So for other things, you can extrapolate to automated sterile fluids and other specimens also. You can extrapolate. Like, for example, you can have comments like if there's a no-grow. So you send a preliminary report, you get a blood culture, the clinician is waiting for your report. If they don't communicate anything, then they'll be little anxious that there's what is happening. So to relieve the anxiety, you have to release a report at 24 hours with a comment saying that at 48 hours there is no growth. We are further incubating sample for next 3 days. So we have a total of 5 days of incubation. What kind of contamination are you getting? Contamination is there, or if you have to improve upon your collection collection methodology has to be improved upon. So all those things can be go on these kind of reports or for blood cultures. Then if the pathogenicity is uncertain, for example, you get odd pathogens from blood, only a single isolate you're getting. So in that case also, the pathogenicity is not certain. In that case, you might have to get a repeat specimen, or you have to correlate with the patient's condition. You have to go bedside and see what is happening to the patient. So this is the first table that they have suggested for the various report categories. The second table they have suggested as to what should be the comments related to specimen collection. Like, for example, you have to promote the culture of cultures. Always collect a specimen for microbiology before starting antimicrobials, and it should be ideally the first specimen to be collected from any patient whenever you are collecting multiple blood samples. Blood volumes, they are always measuring the blood volume, whether it's less than 8, because this is where the quantity is really matters, especially for blood cultures. If it is less than 8, then it is less likely to, isolate a pathogen unless it's a high inoculum infection. Or if they also say that the turnaround time also they are mentioning, and what is the source also. So we have to send always, like they say that repeat blood cultures in pairs, collected from 2 separate vinipunches site after undergoing separate decontamination procedures. So basically, it will always help you to differentiate between whether it's a contaminant or a true pathogen. So always we should insist on pre-antibiotic specimens. So this is one thing that should always be informed to the clinician time and again on every report, that please send us pre-antibiotic specimens always before starting empirical antimicrobial therapy. So whenever you have a fully integrated automation like they have got in Jipmer, so in that case, you can still load all these comments on your softwares as drop-down menus as preloaded comments. But when you don't have these things, then always you can have some kind of a MS Word template where you can copy paste it on your Word files and then accordingly make the PDF and send. That's what we are doing right now. Then there are comments. What exactly what the AST the kind of AST that they're putting up. We call it. Some people call it the preliminary AST or the direct AST. What is mentioned in the CLSI. Once you get a bottle that is coming positive, so what we used to do was make a gram stain. Gram stain, if it is gram negative, yes, most likely is going to be pathogen. We put up a direct susceptibility. We put up as per CLSI. If it is a gram positive, it could be coagulase negative staph. So we can always perform a tube coagulase test from that broth. Also, we can perform a tube coagulase and check if it is tube coagulase positive. Then we can further go ahead for the AST for suspecting that it could be a Staphylococcus aureus also. So once we get a growth, let's say after 6 hours, 8 hours, we get a growth. So we can always put up the colony AST or the final AST with our with manual method or automated method, and then we report it accordingly. Susceptible, intermediate, SDD, and R, these are again clinical. These are all clinical interpretations of what you are reading on your AST reports, of your what are the interpretations of your breakpoint MICs or the breakpoint zones. So this madam already has suggested about told about these things, and these are clearly mentioned in CLSI also, and you have to tell them that what is the meaning of SDD. So wherever the SDD breakpoints are given, you must report, and you have to report the dose also along with that. So you just don't report at SDD, because you have to tell them also that what should be dose at that particular MIC. That also has to be told to them. So you also those who are practicing who are doing the therapeutic indices that we'll talk about in subsequent sessions. What is therapeutic index? So we can always tell that higher the therapeutic index, the better is the likelihood of the patient responding to that particular antibiotic. So that also can be added on our clinical footnotes when we are talking about on AST reporting, or especially for the AST, not the quality of the sample, but AST. Then there's a Fowler's rule, that's PFALLERS, Fowler's rule of 90-60, which says that 90% of the time the susceptible antibiotic will respond, but 60% of the time also it is likely to respond despite showing resistance. So if there is nothing to do, you can still start a certain group of antimicrobials can be started, and it is possible that the patient might respond to that. 60% of times the patient would respond. Then there's what you call a time to positivity. That means the moment you have collected the specimen and moment you enter it inside your automated machine, and from the time it gives you a flash positive. So if it gives you a positive in, let's say, only 4 hours, that means a high inoculum infection. That means the chances of the outcome is likely to be poor in that case. So high inoculum infections or the low time to positivity is indicative of high inoculum infections and poor outcome. And of course, you can also add comments whether it's a catheter-related bloodstream infection or not when the central line blood culture specimen is flagged more than 2 hours earlier than the venipuncture specimen. So all these comments that this is suggestive of CLSI kindly correlate with the clinical parameters and confirm the diagnosis. So they can also start things like, if you want to maintain the catheter, you can always start antibiotic locks also. So those kind of things can be added onto your AST reporting also. Then, of course, whenever we have any kind of a MDR isolated from a patient, like the MRSA or VRE or ESBL or CRE or whatever it is, then it is always nice to mention that please strictly practice the hand hygiene measures. 5 moments of hand hygiene should be practiced, because that is you might think that that's the job of the hospital infection control committee, but that's all. You are also, the microbiologist is an integral part of the hospital infection control committee, and so therefore these comments should also be sent on the AST reports, like hand hygiene practices. You can have the cohorting of patients, like in many of the developed countries, they do have separate MRSA wards are there, ESBL wards are there, so that there are no sick patient with an MRSA sepsis or MRSA wound infection is not lying next to a patient who's recovering from a clean surgery. So it should not be like that. So they should be kept further apart. and there should be adequate distance between their beds also. We should try and use give the advice to on the reports that to use separate dedicated equipments like BP cups and all those things. So you should comments on cohort nursing should go like MRSA ward and all those things. 5 moment of hand hygiene should also go on your reports, and cautionary reports whenever you isolate organisms which have the potential to create an outbreak like Burkholderia, Stenotrophomonas, CRE Klebsiella, Acinetobacter. They are very common organisms which are likely to cause an outbreak in a particular unit. So if you get these kind of bugs, so that also you should report. And then the moment you get a second bug, you should start doing the outbreak investigation, doing the indexing of the patients and all those things. Then there are specific organism and antimicrobial related comments, like if it is an MSSA, what does that mean? If it is an MRSA, what does that mean? So in the subsequent reports, I'll be telling you what we are doing it. Everybody can customize their own reports. That's not a problem. There are no set rules, but yes, MSSA means this. MRSA is basically a target mutation. So that's why you can extrapolate to all of the beta-lactam drugs. So all those things, certain set of rules are there, but some of the things that you can make on your own, you can customize your comment the way that you want to. Like I'll just show you what MSSA we write on our MSSA and MRSA reports. Then I said that about SDD, if for cefepime and enterobacterials, the SDD is defined. So if we get an MIC of less than 2, then this is the kind of dosing that we can give. Now, one thing that CLSI does not mention over here, but ideally we should do it that if MIC of less than 2 is there, it's considered to be susceptible, and recommended dose is 1 gram twice daily in extended infusion. So I think this one part, CLSI, these are typical classical, these are CLSI comments only, which have been added on this particular table. So things like, PKPD based treatment comment should always be given on these reports. Similarly, then if you remember last time also I had spoken about associated resistances, like if it is, for example, if you're getting Pseudomonas aeruginosa, and even if it is susceptible, then it is still likely to develop resistance during treatment because of the inherent presence of the chromosomal AMC beta-lactamase. Similarly, Staphylococcus is associated with fluoroquinolone resistance. It is likely to develop despite susceptibility. It might develop resistance during treatment. Same thing I'll be repeating again for the ESCPM group of organisms like Enterobacter, Enterobacter cloacae, Klebsiella aeruginosa, Serratia. So they are likely. So these are certain groups, certain bugs where repeat isolate or a repeat specimen should be sent, and because the very existence of this particular pathogen is an indication that this is likely to develop resistance during treatment. So there are certain dangerous bugs, so therefore caution has to be sent, and therefore repeat culture has to be asked for. Similarly, same thing goes for Enterococcus also. If we got high-level gentamicin susceptibility, so we don't report it as susceptible, we report it as synergy. We don't have breakpoints for high-level gentamicin. There actually synergism shows that it is going to be synergistic with ampicillin in serious infections like endocarditis, bacteremia, and meningitis. Similarly, colistin warning has been issued by CLSI and by FDA that if it is less than 2, then it is to be considered as intermediate and not as susceptible, because susceptible breakpoints are still not validated by FDA. So they are still under consideration. So you have to be careful while reporting colistin and what methodology you're using. You're using automated, you're using colistin broth disk elution method, whether you're using broth microdilution. So all those things also need to be mentioned. What is the validated method that you're using for colistin MIC detection? Similarly, for inducible clindamycin resistance, if it is ICR is positive, then you have to convert clindamycin should be given as resistant, and should not. And you can send a footnote that it should not be given for serious skin and soft tissue infections, as constitutive resistance is likely to develop during such long-term therapy. So ICR also you have to report inducible clindamycin resistance. Then there are predicted susceptibility related comments also. Again, these are all CLSI based comments. You can take from this particular article, or you take from M100. The previous slide also you can take from CLSI or M100. These are all given over there. CLSI slightly complicates it because you have to search for all these comments. In this particular review, it is nicely been compiled. Like for example, ceftriaxone, if it is susceptible or resistant in Enterobacter C, then it can be extrapolated for cefotaxime also. Similarly, erythromycin, if it is susceptible, can be extrapolated to azithromycin and clarithromycin also. So this is the list that is classically given in CLSI M100, and so you can refer to this particular review article or to CLSI also if you want to extrapolate. So if you are testing erythromycin only and you're not reporting any other macrolides, so you can send this report that in this particular case erythromycin is found to be susceptible, so it can be considered to be susceptible to azithromycin or clarithromycin as well. So these kind of things also you can add on your comments. Now, intrinsic resistances have been discussed extensively, I think, in the previous first and second sessions also. And this is, I won't be discussing it, but just I want to mention that they are given under the Appendix B of M100. If you pick up any version, doesn't matter, 2020, 21, 22, doesn't matter. Appendix B of CLSI, you can say, and many of the vendors are also providing charts for intrinsic resistances. UCAST has separated it into two separate documents, like expected resistance phenotypes and expected susceptible phenotypes. So in M100, basically they're all combined together. So it's slightly complicated in M100 to search for in an M100, whereas in UCAST it is very clearly given separately for resistant phenotypes and susceptible phenotypes, and these are available on the UCAST website. If you just Google version 1.1 of March 2022, this is around 8 pages and 5 pages. So they're very interesting. If you just go through it, you can always add these intrinsic comments on your on the clinical footnotes. Then if you were to classify the types of comments or the clinical footnotes on the AST reports, so this one particular paper also I think I had shared in the previous presentations, the microbiology investigation criteria for reporting objectively, a framework for reporting and interpretation of clinical microbiology data. So this is also was a very interesting review guideline, and in which they had, made around 20 points which should be considered for proper clinical microbiology reporting, like what is the specimen type, what is the sampling period, what is sampling strategy, target organisms, geographical settings, clinical settings. So these are all the pre-analytical phase. So what are the comments, like for example, if you're getting a urine specimen which has got a delayed transportation time, so multiple things will be there. Sampling strategy is wrong, sampling period is wrong, maybe the sample or the specimen type is it's not a clean catch midstream urine sample. So all these factors, all these 20 points can also be used. These are factors that impact the AST reporting. So these factors, if you can take down this table, they're very interesting, and these are the factors which actually affect your. So these are basically the pre-analytical, analytical, and the post-analytical points, where all these things can be considered, and on the basis of which you can write down comments on your report, like is it the kind of sample, what is the processing you're doing, what are the methodology that you're following, whether this particular test is in the accreditation scope or not. That also you can mention that this particular test is not in the scope for accreditation of this particular lab, or this is out of the scope for accreditation. So that also you can add over here in your clinical footnotes. What are the populations that you're dealing with, a pregnant lady or a pediatric or infant? So all those comments also can come. So despite automation, what I'm trying to say that AST reports are very, very different from biochemistry and pathology auto-analyzer reports. So auto-analyzer, you switch it on in the morning, you pass your quality control, you pass multiple quality controls, you do a split sampling, you have a check. So once you start just feeding all the serum samples, and it keeps on analyzing, keeps on giving you the report. Whereas things are very, very different in AST reporting, because AST reports require a lot of brainstorming inside. We have to check for what is the specimen quality, because garbage in is garbage out. If we get a delayed transportation time, overgrowth is there, especially like in urine samples, or if there are fastidious organisms in CSF that may die during the transportation time, or the collection is not adequate, we have to look for the acceptability and rejection, also the transportation time, the temperature in which the transportation was done or the sample was stored, repetition of the specimen also, and the patient details on TRF. So these are the things, whether the patient is adult or a child, a pregnant female, whether the patient got any, what are the other parameters, like your renal function test, the liver function test, what kind of antibiotics the patient is taking, the specimen correlation with culture and wet mount, like ma'am was saying, gram stain finding. Gram stain is one of the most important. It is the most important clinical stain that we can do on any sample, and we need to correlate with other findings also, like Vidal. We may get a positive blood culture, but a Vidal negative. So you have to mention that it's probably in the early phase of the illness that the blood culture has come out positive and Vidal has come out to be negative. So these kind of reports, these kind of comments can also go on your AST reports. Like, of course, SIR and SDD also has to be told that if it is susceptible, that means it is likely to respond during the recommended doses for this particular antibiotic. Then there are footnotes which are related to the organisms, intrinsic resistances, therapeutic index, if applicable, selective reporting, best suited antimicrobials, interpretation of the possible MDR types. What does MRSA, VRE, HLRA, SBL, AMC, what does it mean actually? Then site-specific and PKPD-based dose adjustments and aid-related comments also can go on the clinical footnotes. Then comments on interpretive reading. Now, interpretive reading is slightly more advanced, and I think I'd mentioned before also that there's two very interesting reviews by Gunnar Kalmeter and David Livermore on interpretive reading. So, an exhaustive review has to go into understanding what interpretive reading means, and then, in fact, I was just browsing through the questions. Somebody was asking me, and they said that one of the first questions that please let us know that how do we know whether this is NDM or a AMC or a hyper AMC or a ESBL or a AMC plus ESBL producer. So what are the various combinations of this is susceptible, this is resistant, this is intermediate, so what are the different combinations that we combine together? And I think I briefly in my previous session also I discussed about what is interpretive reading. So that requires a little bit of brainstorming what exactly it is. Then, of course, one of the highest form of reporting is personalized antibiotic reporting. Ma'am had mentioned in the initial slides that again involves a lot of parameters to be taken from the patient, whether the patient is, what is the condition of the patient, what are the other reports like TLC, DLC, ESR, CRP, creatinine, procalcitonin. So all those things have to be taken into account, and whether the patient is already so it's a tailor-made report. Basically, personalized antibiotic reporting is one of the very difficult things to do. It's very tailor-made, and you have to customize according to the patient requirements. So, like I said, there are certain known facts. There are certain known facts, and there are certain customized facts which can go as footnotes on your report. Like, for example, the known facts. We know that universally known resistance and susceptibility. So this is a known fact and can go on your AST reports as comments that this is a intrinsic resistance, natural resistance. This is a target-based resistance. Like, for example, because MRSA, you cannot extrapolate it like ESBL. You cannot extrapolate cefotaxime to ceftaroline. But in case of MRSA, it's a known thing. MRSA, it is resistant to everything except for the 5th generation cephalosporins. Then there's a known fact that blood culture volume has to be adequate. If it is less, it does not give you a positive test. So that's also given in CLSI M47. Then CLSI rules for representative antibiotics. I just mentioned briefly in one of the tables that what are the representative antibiotics. That is also very clear-cut known fact. Antibiotics not to be reported in specimen infections. I think displayed on the slides previously. I'll just display it again. Then sterile containers for cultures, culture biopsies, and normal saline. These are basic known facts. These have to be added in the culture reports. Whenever and wherever possible, pre-antibiotic specimens have to be added if you're getting no growth in a patient who has been symptomatic. So in that case, you have to say that you should have sent a pre-antibiotic sample, or probably you can send the next specimen just before the second dose, because by the time the first dose wanes off and just before you're about to give the second dose, the trough levels have fallen. So ideally, just before the second dose, you should take the sample for culture, in case you've given the first dose already. Then specimen transportation time and temperature. So again, these are very known facts that if you delay the transportation time, then commensals will grow and the fastidious organisms will die out. So never delay your cultures. Then you can customize some of the footnotes, like what are the choice of antibiotic, what is the dose, what is the frequency. Then you can customize your PKPD-based footnotes, customize your age and pregnancy-related footnotes, customize your hepatic and renal conditions-based footnotes, topical and systemic antibiotics to be given, and selective reporting. So all this can be customized as on your AST reports. Then in vivo development of resistance, which I just told you about, the Pseudomonas and other ESEPM group of organisms. This is the slide which I had demonstrated in the previous sessions also. This is a known fact that which antibiotics are not to be reported in which specimen and patient types. A few examples, like in blood, do not give tigecycline. So you can mention in your footnotes, if like patient has, the patient's come from the ICU, patient is having sepsis or VAP, so it is quite likely that he might have been started on tigecycline in primary bacteremia or in CRBSI. So you have to tell them tigecycline is not to be given. So these kind of footnotes should go on your AST reports. And this is also a known fact. This is clearly given in the table 1B of M100 about what are the antibiotics not to be reported or given in CSF isolates. In abscesses, what not to give. Lungs, what not to give. Ma'am had just mentioned about daptomycin not to be given in cases of pneumonia. Urine, you don't give macrolide, tigecycline, chlorphenicol, and clindamycin. In children, you should avoid fluoroquinolones, preferably less than 12 years of age, tetracycline 8 years of age, chloramphenicol, cotrimoxazole in infants also. So these are things that you need to avoid, and you can mention it on your report that we did not report XYZ drug because this is a 2-year-old child, or we did not report these antibiotics because it's a pregnant female. So, and then there are site-specific antimicrobials, like only meant for only this site, like tigecyclines. Last time also, this question came that why tigecycline cannot be given for bloodstream infections, because it has got a very, very high volume of distribution. The moment you give it parenterally, immediately it diffuses out of the blood and goes into the skin and soft tissues. And that is where it is meant to act, only for complicated skin and soft tissue infections. Nitrofurantoin only for lower UTI, fosfomycin only for lower UTI for E. coli and E. fecalis. Again, this question was there, I think, that can it be given for Klebsiella? No, I won't give it in writing that it can be given in Klebsiella, because what we are witnessing over here, that we are getting barely a zone diameter of maybe 15-16 millimeters with fosfomycin and Klebsiella. So in any case, there are no breakpoint zones existing. I would never recommend fosfomycin for Klebsiella. Similarly, beta-lactams also. Now, based on specimen type, for example, this is a report that this is a comment that we sent on a report when I was in a previous institute. We got a pus swab from the umbilical stump of a neonate, who was previously hospitalized in an ICU in a private hospital, and that swab, it isolated a carbapenem-resistant Klebsiella pneumoniae. There were no pus cells. There were occasional gram-negative coccobacilli. The main thing was there were no pus cells. The patient was asymptomatic, so we did not put up the AST. We just did not put up the AST. We just reported that the case has been discussed with the clinician, and there are no systemic signs and symptoms, and the patient is afebrile. Since the swab collected is superficial, transient resident flora, this kind of flora does not represent the true pathogens. This wound does not need systemic antimicrobials and may be treated locally with debridement, antiseptics, and topical powders like Neosporin, bacitracin, and sulfacetamide combinations. So this was case we discussed. Like this first point, why I'm writing, why I do have the confidence of writing all these things, because I have spoken to the clinician. If you don't speak to the clinician, if you just write things blindly, then these reports won't be acceptable. Once you speak with the clinician, then you can send these kind of reports that we have discussed the case. This is not to be reported. This is most likely superficial pathogen. So always should discourage the use of swabs. They are the most useless samples unless you are going in for surveillance. That's a different thing. Surveillance as in hospital infection control surveillance. That's a different thing. Otherwise, they are not required. If we get a coagulase negative staph, then we can write this report that they are resident skin flora. Isolation of cons does not warrant the use of antimicrobials unless it is a proven case of CRBSI, then symptomatic CRBSI. Isolation of cons indicates improper asepsis or the phlebotomy site. Kindly repeat blood culture after proper skin asepsis. So this is the kind of report that we send on specimen type. Then if we are getting repeatedly we're getting blood cultures, contamination we are getting, so we can always send reports like this is improperly collected sample, or the phlebotomy techniques are bad. So please do follow these protocols. So proper blood culture collection protocol has to be mentioned on the report. So if you're getting cons from a patient, then you can send this, copy paste this particular comment and send it on the report that this is how the phlebotomy site is to be handled, how to take the sample, how to give the proper contact time of the antiseptic, and use only sterile gloves. All those things you have to mention. Then again, like things like urinary catheter are not acceptable for urine cultures. Endotracheal tubes are not representative. Whatever that we are isolating from the endotracheal catheters are not the true pathogens. So we would please send us endotracheal aspirates or bronchoalveolar lavage. So these are the kind of comments that you can send. Then, as mentioned, this is a very nice table that should be there in all the wards and all the, I would say, all the sample collection areas, specimen collection areas, that the first specimen to be collected is the blood culture always. The first to be collected is blood culture, and always insist on pre-antibiotic specimens. And that's why I've always been advocating for a 24/7 microbiology lab, because cultures should not be delayed under any circumstances. Culture should never be delayed. And if there's no growth at 48 hours, so you should have sent a comment on that there's probably antibiotic has been given, and maybe in the next subsequent dose or third dose, I mean, basically just before any of the dosing, before you start the antibiotic dose, you should collect the sample for antibiotics. There's a chance that patient may not have been responding to the empirical therapy. So just before starting the next dose, you should take the specimen for culture. And like I said, you should promote the culture for cultures, and always cultures, whether it is blood culture or any other site, they are the first specimen to be collected from the patient and sent to the lab as early as possible. When we talk about automated cultures in the bottles, we can always tell the clinician that, okay, you have sent us a pleural fluid, so it would have been nice if you could send it in the automated blood culture bottle, treat it the way that you treat blood. So you can send blood, CSF, pleural fluids, pericardial fluid, synovial fluid, aspirates, which are collected aseptically. Intraoperative biopsies and tissues, they can all be sent to in automated blood cultures. So as a rule, enrichment has to be made compulsory for all these specimens for better isolation of pathogens. So the only one thing that you have to ensure, like for CSF, pleural fluid, pericardial fluid, if you're collecting the specimens, let us say if it is in a syringe, so maybe 1 or 2 drops you can just leave for grams, and rest you can put inside the blood culture bottles. You'll get, in that case, you get 2 samples. You'll get one is a blood culture bottle, one is a syringe probably, which will have just around half an ml of the fluid, for which you can do a gram staining and do the immediate reporting. Then you can customize your comments based on what kind of target organisms that you're getting. Like, for example, this is the report that is from September last year from a previous institute. Like I said, that I'm a promoter of HUNET, and this is a HUNET generated report. This upper half is a HUNET generated report. We've isolated enterobacter cloacae. Now, I've been probably every session I have told about this particular bug, along with Pseudomonas also, that they are likely to develop resistance during treatment. And in fact, this has already developed resistance and to cefepime, because the dictum is that if the cefepime MIC is less than 2 as per CLSI, you can start cefepime as a drug of choice for the AMC producers. But in this case, cefepime also resistance. So with piptazo, we can start along with gentamicin. That comment is over here. Like this entire comment, enterobacter cloacae contains inherent presence of inducible derepressed chromosomal AMC beta lactamases. Resistance to ciflotaxime and ceftriaxone indicates a possible coexistence. So it is also possible that the resistance to ceftriaxone or ciflotaxime could also be because of the concomitant presence of a ESBL. So we are saying that this possibly ESBL is also positive, AMC is also positive, primarily because of resistance to cefoxitin. Right. So this is a kind of report. And then, since this is an isolate from blood, so because the best specimen for therapeutic indices are blood cultures, because we are measuring the MICs in serum. So that's why they are the best representative. We'll talk about that later on in the subsequent sessions about therapeutic indices. So again, you can customize your comments based on, like, if you're getting enterobacter cloacae or Klebsiella aerogenes or Serratia, so these kind of bugs, you can add these kind of the comments. Then, based on the therapeutic indices, we have again added the comment that you can give piperacillin tazobactam. This has been highlighted in bold. They've got a nice therapeutic index they've got, so they can be given as combination agent, because this is a blood specimen, so it is a serious infection. So monotherapy should be avoided. It should give as a combination therapy of piptazo along with gentamicin, which seems to be a decent combination as per therapeutic indices, and therefore, and since we had taken the history of this patient, this was a 3-day neonate having seizures, so most likely it was given phenobarbital or phenytoin wasn't given. So therefore, we had also added this comment based on the history that these drugs are there. So may cause drug interactions, kindly consult the clinical microbiologist or pharmacologist if there are any drug-drug interactions. And like I said, this is the 5 moments of hand hygiene reminder is also gone on the footnote also. As you can see over here, it's on the footnote also. So that is the kind of exhaustive reporting that you have to do at times when it comes to personalized antibiotic reporting. Now, when it comes to personalized antibiotic reporting, this is one of the examples that I think I must have given 3-4 times in multiple presentations. One of my friends, he's an orthopedician, he consulted me, he sent me a WhatsApp that this is the automated AST report of joint aspirate. So tell me what antibiotic should I give this to the patient. This is a case of chronic prosthetic joint infection. What is the best treatment choice? He told me. And now the patient is an 80-year-old male that he's got an aortic aneurysm, and he was operated as a high-risk case, and we cannot reoperate him. So we need to salvage the prosthesis. So now what do? I need to retain the prosthesis. Now this is a very special condition, because whenever you get a PGI, so the first thing is to do is to remove the prosthesis. Now the prosthesis would already be having some kind of biofilm would be there, or some, even despite removing some the inoculum by aspirate or something by local anesthesia. You cannot remove the biofilm by just aspirating whatever fluid or abscess is there. But then what do we do? So I gave him an option that you can go in for, this is the kind of things that you can go. However, this is not a blood culture report. This is an aspirate report. But still, I suggested that you can go in for a combination of piperacillin tazobactam and gentamicin. Or maybe you can go in for cephalosporin and gentamicin, because this was susceptible and they all had decent therapeutic indices more than 1. In case the patient does not resolve clinically within 2 weeks, because this is normally we would give an antibiotic timeout around 72 hours, but since this is a bone infection, so we gave it an antibiotic timeout of around 2 weeks. So wait for 2 weeks. If the patient does not respond clinically, you may give Miro and Amica, because both of them are slightly higher end as compared to piperacillin tazobactam and gentamicin. So this is the kind of report that we sent to him, and we told them that all beta-lactam drugs should be given as extended infusion only of not less than 3 hours. And IV and oral switch may be done with ciprofloxacin 10-50 milligram BD after 4 to 6 weeks can be done, because Cipro is there somewhere, I think. Because Cipro is there. Cipro was also susceptible. Okay, Cipro was susceptible. The therapeutic index was 2. So we gave an antibiotic timeout around 2 weeks, and but he told me that no, tell me the exact antibiotic posology. I don't know how to give these antibiotics. Tell me how to do. So I made this specific chart for him, that this is the dosing recommendation as per ITSA guidelines and AST report and MIC based therapeutic index. So this is the kind of this you may start as a first line. If it doesn't respond within 2 weeks, then you shift to meropenem and amikacin. So I told him piptazo 4 gram every 8 hourly, total dose of 13.5 grams, IV extended infusion not less than 3 hours. So use 0.9 normal saline or ringer lactate can be used, and the entire infusate has to deliver 4.5 gram in around 3 hours or so, and for duration of 4 to 6 weeks. So this is the detailed kind of entire antibiotic posology I made for him, and he said that yes, it's been 3 weeks post-op now. After this entire treatment, he said that the patient is 3 weeks post-op now. The serological markers have come down and all is normal. Stitches are dry and removed. Clinically, the knee is silent. Could give Genta for 9 days as creatinine started to increase. Meropenem as infusion going on. So basically, they gave him, I think, meropenem and gentamicin, I think they gave him. So I discussed with him and we said that, okay, let us talk about the guidelines. What does ITSA say? ITSA says about the prosthetic joint infections. Let us talk about that. So we can go in for ciprofloxacin 750 milligram BD on a long-term basis. So in this case, Cipro was susceptible. As you can, I showed you in the previous slide, it was susceptible. And 750 gram can be given in this case as for chronic oral suppression. So this is the level that you may have to go when you come to, you have to give comments on specific reports and do personalized antibiotic reporting. This is the kind of involvement the clinician will have with you once you are into this thing, right? Similarly, you can have a comment that you are not putting up the AST because this is a contamination we are not putting up. This is a commensal or contamination we are not putting up AST. Or if you're getting any atypical bug like Achromobacter xylooxidans or maybe odd bugs like something bacter you're getting from otitis media, so you may not report it. You just say that if it is patient is symptomatic, then only send the samples. So as of today, as we sit over here in my institute, I don't have automation right now, but we're likely to start automation maybe in a couple of months. But we do curveball distribution, and we have HMIS. So what we do in our institute right now is that all reports are made on HUNET. We have a team. The way that we do the AST reporting, and then somebody sits on the HUNET and we do the selective reporting. We add a comments from our MS Word template that we have made. I'll just show you some of the snippets that we've taken from our template. And selective reporting is done, and we generate a PDF file. And then on that PDF file, we copy paste the remaining part of the MS Word template and send by WhatsApp and upload it on the HMIS, print a hard copy and send by snail mail. So that is what. Immediately because previously questions were asked that how do you send your reports? We don't have HIS. What do you do? So this is what we do is that we generate the reports, or we generate a PDF from HUNET. We do have an editable PDF, so we can just edit, add the text. You can add that particular template because we are not doing therapeutic index reporting. So there's only a one-page report that goes from our side. We make the PDF, so upload it on our HMIS. Send it on WhatsApp also, because the clinician's name is there. We can find out who's the clinician from our HMIS, and then we send the hard copy also by snail mail. So this is one of the samples of the reports that we are sending from our institute. This is the ID number, the patient details are all there, and then like clinical footnotes are there. The comments on interpretation, or like we are putting up resistant, intermediate, and susceptible. Then we also reporting on a comment that this is a selective antibiotic reporting is being done, and we also reporting that this is the intrinsic resistance for Klebsiella that we are getting, and whether we can go in for carbapenem sparing regimens or not. And in this case, we recommended cefepime. The dose also we recommended 2 gram every 12 hourly in mild infections, and 8 hourly in severe infections, as extended infusions of at least 3 hours. So this is the organism we have included. We have told that this is cefoxitin resistant, and it is possibly a AMC beta-lactamase producer, along with because this is an AMC beta-lactamase producer. So we should not give third generation cephalosporin. So that's why we have withheld the report of cefotaxime over here, and we have also told that what guidelines are we using. We are adding comments on intrinsic resistances. We are adding comments to avoid carbapenems in AMC producers, especially imipenem has to be avoided. We may, if there is no other choice, we may go in for meropenem as a combination therapy also. So this is the kind of comments that we are adding, and of course the PKPD based treatment, like when to give the extended infusion for beta-lactams and as a single OD dose for amino glycosides. So this is, we have highlighted also this amikacin and cefepime. So we are highlighting it also so that clinician can see clearly and loudly. They can see that okay, this is to be given and this is to be avoided. This is another example of how we are sending only the reports of topical antimicrobials. Like for example, this is the case of ear infection, probably a CSOM. So ideally, we should have done a Gram-Sin also on this. And of course, E. coli and CSOF is not so common. We could have got like Staph aureus or Pseudomonas. But since we got E. coli in a pure count, so we said that it's a heavy growth and its ESBL is negative. And we report only topical antibiotics like amikacin and ciprofloxacin we reported over here. And we also said that please attempt treatment only with topical fluoroquinolones, because again, like I said, we discussed and spoke to the clinician that is the patient symptomatic? No, they're not symptomatic. They're just having a ear discharge. So we just, okay, if the patient is not symptomatic, there are no systemic signs and symptoms of fever or anything, the counts are normal, then in that case, we'll just go in for a topical antimicrobial. Or what we can do is that we can always, if we don't have any other choice, we can always refer to guidelines like John Hopkins or Stanford's or ITSA guidelines. So there are standard guidelines that we have. The apps are there on our mobile phones also, and we can go in for, we can suggest topical antimicrobials like Neosporin, Polymyxin BN. Hydrocortisone is also one of the possibilities that can be given, which is followed as a standard treatment guideline from these institutes. Then again, we have similarly, we have got an ENT case where you isolate serratia, again, which is of doubtful significance. We don't know, but then since it is serratia, so we always send a report of caution that serratia is, it's an AMC producer. So we have to be very careful. Do not prescribe any of the beta-lactam drugs or BLB combinations like amoxiclav. Don't use that. Don't use carbapenems. So Whether it's a true pathogen or not, we don't know, but we have recommended only ciprofloxacin, and that too on a topical basis. So last time you can see best possible option in this case is topical ciprofloxacin may be used. So that's how. Again, this is also this is the case that I discussed this previously. The same case again, amikacin and cefepime given in AMC producing Klebsiella, where we discussed the dose also. Now, this is what we are reporting for MSSA, the clinical footnotes. So, as you can see, the time of the dispatch of the report is also going. You can see a date and time and all the reports. You can see previously also the date and time of the report is also going. That's again this WHONET generated. I'm not doing anything separately. It's WHONET is taking out on its own. So, this upper half from this part above, everything is given by WHONET, but the lower part is that we are adding on our own from our MS Word templates. The MSSA, all Staphylococcus isolates are intrinsically resistant to aspirin, ceftaroline, naltrexone, polymyxin, being colistin. And MSSA means that you can give beta-lactamase stable antibiotic like cloxacillin and dicloxacillin, nafcillin, all those things. And we also told them not to give drugs like ticycline, linezolid, rifampicin, or reserve drugs should not be used with precaution. So in this case, beta-lactamase stable oral penicillins like cloxacillin, diclox, fluclox, and maybe supplemented with topical gentamicin can be given, because I think this was a superficial wound from ortho. So with topical gentamicin or chlorphenicol, depending on the extent of infection, can be given. This is the report that we are sending for MRSA. This is again, this is a skin and soft tissue infection from pediatric surgery. This is isolated MRSA. In this case, we have suggested vancomycin as per standard treatment guidelines, and vancomycin is not to be given as monotherapy, always has to be supplemented with any other drug like clindamycin or any aminoglycoside or maybe fluoroquinolone, but best it would be that would go with a agent that has got a different site for infection. Like vancomycin is a cell wall active agent, it can be given with the aminoglycoside, so they are synergistic with each other. So in this case, we have prescribed vancomycin 15 to 20 milligram per kg, and these are prescribed as per the standard dosing, which are mentioned either in like this is a pediatric patient, so we have referred to Nelson in this case. In adult patients, we are referring to Harrison, or we are referring to Mandel, or we are referring to books like these guidelines from John Hopkins, and for Sanford guidelines also we are referring to. So we are giving in this case the actual dose also, not to exceed 2 gram per dose, amikacin so and so dose. If D test is negative, clindamycin we added. So all these detailed footnote, what does MRSA mean, what does MSSA mean, what are the drugs which are not to be given, and what to give in this case. So this is the kind of clinical footnote that goes from our side as of today. Then we have got again a CSOM case of CSOM, where we have isolated Pseudomonas and we have reported only and only topical antimicrobials. And we've also mentioned that it is intrinsically resistant to all these antibiotics and avoid the use of beta-lactam drugs. So again, we have reported over here, in this case, please attend treatment with topical fluoroquinolone with or without topical tobramycin, depending on the extent of infection. Now, what happens when we get two organisms from one patient? Now, this is a case of, this is from Department of Surgery. We got one E. coli and one Proteus in this case. And this E. coli was, again, ESBL positive, and it was negative for AMC beta-lactamase. Proteus is possibly, it was mirabilis. So it is basically not AMC producer. Vulgaris is normally AMC producer. So in this case, it was only susceptible to meropenem and intermediate to amikacin. In this case, this was susceptible to meropenem and amikacin both. So we recommend that please combine meropenem 2 gram 6 hourly in extended infusions or not less than 3 hours may be used along with amikacin OD 15 milligram per kg day, single dose for not less than 7 days, because this was a high inoculum infection. So that's why this is moderate growth. Sorry, yeah, this is moderate growth. So basically moderate inoculum infection. So we recommended a dual therapy for both the bugs. We are recommending the same. Here also is written meropenem along with amikacin. So this is the clinical footnote that we have sent. We're suggesting the dose. So we are actually suggesting them what is the best possible treatment. We are not saying that do this only. So we are, in both the cases, we are suggesting the same treatment guidelines. Now, since we don't have automation right now, we are in the process of getting it. What happens when we get like from an ortho case, bone and joint infection, you can't avoid it, but we have got a glucose nil fermenter that we can't identify. We have put up a panel for Acinetobacter, but this is not Acinetobacter, and it is pan susceptible to all, but we can't tell them on the report that is all pan susceptible. So when the ID is not available and breakpoints are not available, and you can't follow the breakpoints of nil fermenters, because nil fermenter breakpoints are also in MICs. So there are no breakpoint zones for nil fermenters. So that's why we have written that AST report not reported for this particular bug, because distribution method has not been systematically studied. Therefore, for this organism group distribution, testing is not recommended. So we just spoke to the clinician that it appears to be pan susceptible. You can give an empirical treatment for piptazo along with Genta. Maybe you can give. A patient might get treated, but then right now we cannot report because we don't have the ID of this organism, we don't have the MICs, and we can't report it just on the basis of the curveball distribution. So there are times when you really get fixed, and we got problems when we are on a manual mode, but still we are continuing. Now there was a time when I had an automation both in culture and AST, but there was no HIS LIS or any commercial software. It is the opposite thing in the previous institute. So, but one thing which I already had was HUNET. So that really made the life very simple. So reports were made on HUNET, the way we are doing it right now. Comments were added again from our MS Word template. Selective reporting was done, and MIC quotient and therapeutic indices were made on the MS Word template only. The printout was taken, it was signed, stamped, and the hard copy was scanned as PDF and then sent by WhatsApp and snail mail. So that is how we did in the previous institute, where I didn't have any HIS LS, I didn't have any patient details, but yes, we did have, it was a small institute, we did have phone numbers of all the clinicians. We could always call them up and ask for patient details also. So like, for example, this was a case of Staphylococcus aureus, which was MSSA. This is MSSA from a pyogenic specimen from orthopedic, from case of, from an ortho case, where, if you see, this is MSSA from tissue, and the automated ID, AST, and KBB, curveball distribution method, both was done. So this is written over here. Like the methodology also be mentioning in the comments that AST was reported by this particular method and curveball distribution also. And all patient demographics were mentioned. Patient was a 12-year-old male, so tetra was reported. Because patient is more than 8 years, so therefore tetra was also reported. Specimen date was 7th October, but the dispatch date was 4 days later, because we did the enrichment of the BHI broth. We did the enrichment, and the patient, this bug did not come positive on the primary sample. We had to do the BHI enrichment, and only after that we got the Staphylococcus aureus. So that's why there was a delay, because of the enrichment period. And like I said, the dispatch date is and time is generated automatically by HUNET. And inducible clindamycin resistance was reported. MSSA for MSSA cefoxitin was tested, and oxacillin was reported. Amikacin is not reported because there are no CLSI breakpoints for amikacin. Only Genta we normally report. SIR I could have added, but that's not there over here right now. That could have been elaborated. 5 moments of hand hygiene have been mentioned over here. The signatory authority is also mentioned over here. Interpretation, what does MSSA mean? That is also mentioned. What are the likely antibiotics that this patient is likely to respond to? Also has been mentioned. Avoidance of glycopeptides and linezolid is also mentioned in the clinical footnotes. And selective reporting has been done without the MIC quotient, because this is a pus specimen, this is not a blood specimen. MIC indices or MIC quotient are thoroughly validated on blood cultures, but not completely validated on tissue samples or pus aspirates or from other sites, because we don't know what are the concentration of the specimen that of the antibiotic which is going to reach over there. So we really cannot judge exactly whether the antibiotic concentration, like tetracycline, might have a particular concentration in the serum. We know that, but what concentration it will have in the bone, we don't know. So that is why you can't extrapolate it completely. You can predict, but you can't totally extrapolate. And we have reported linezolid for IV to oral switch only for MRSA. This could have been added. I think we have reported linezolid also. Then this is another report of MRSA from blood culture in a neonate. Again, we have given the interpretation, what does MRSA mean, and what are the antibiotics that can be given. Vancomycin can be given not exceeding so-and-so dose, along with gentamicin as so-and-so. Kindly use antimicrobials judiciously. And again, we have held back the report of linezolid and rifampicin over here. So like Mehmet mentioned that rifampicin is not to be given. In fact, we whenever, even though very rare, but whenever you got resistance in rifampicin, and we went back and investigated, we found the patient had taken ATT. So rifampicin resistance, if it is coming out to be as resistance, then you should consider that the patient must have taken ATT. So basically, this was a blood isolate of MRSA. So we went in for a MIC quotient or therapeutic index. I'm not going to discuss this in detail. We'll be doing it in the subsequent sessions. Then what happens when we get odd or like atypical isolates like Ochrobacterium anthropi? This is the AST that was generated by the automated system. We reported it. It was single isolate, but then we also sent a report of this clinical footnote that is a non-fastidious gram-negative motile non-fermenting bacillus or all these things. So whether it is a true pathogen or not, that is for the clinician to determine. And we always want a repeat specimen to see whether we are actually in the same bug again. Again, like Sphingomonas possum mobilis. So again, the automated system will give you some kind of susceptibility or some AST they'll give you, but then you have to send a clinical footnote that it may or may not be a pathogen, so please correlate clinically. Then, like I mentioned before, that isolates which have got outbreak potentials, like Stenotrophomonas maltophilia, right? So we have had outbreaks before. We have had outbreak of Burkholderia also before. So these are like multiple isolates have been recovered from blood cultures from a particular holding area, and there's a close temporal association. This indicates an outbreak. So we have to tell them that this is possibly an outbreak. Please be careful. Please repeat blood cultures to establish whether it's a true pathogen or not. Then these are the intrinsic resistance, because Stenotrophomonas is resistant to many of the antibiotics. So you have to mention that these are antibiotics which are resistant. And then the susceptibility has been done because the same pattern was being followed by most of the isolates. So this was outbreak of Stenotrophomonas maltophilia from the holding area. Now what happens when you don't have anything? We don't have anything, like everything is resistant, except for maybe chloramphenicol is coming as susceptible over here. This is a neonate basically. Colistin is being tested by, we are mentioning also the colistin MIC was tested by colistin broth disc elution method, CBD method as recommended by CLSI M100, and please do not attend monotherapy with colistin. So in this case, we suggested that, okay, we got nothing over here, maybe you can go do colistin along with high dose of chloramphenicol. You can try in this particular dose in 4-divide dosing. So again, all these dosings are as per Nelson's for pediatric patients. And there came a time when because chloramphenicol was not there in the automated panel, so we had put up the discs. So there was a time when discs was also not available, so we were not so again, we could just project that it's possibly susceptible to chloramphenicol. So despite not having a disc like the 90-60 rule of Fowler, we also just said possibly it could be susceptible, it could respond. And considering the fact that you're giving extended dose of colistin and with chloramphenicol, patients of CRE sepsis, at least children and infants, they did recover to quite some extent. Then this Pseudomonas aeruginosa from a vulvar tissue. Now this is a patient where vulvar tissue was sent to us and Pseudomonas aeruginosa was isolated, and there were again no systemic signs and symptoms. We did report the antibiotics. We said that, kindly treat with local treatment like Neosporin. So despite of this susceptibility, we have to tell them don't treat with systemic antimicrobials. Maybe we could have held that also. We should not report this also. We could have just said that just give the patient the topical treatment. So we said that we've given advice for local treatment. Avoid systemic antimicrobials. Intrinsic resistance to Pseudomonas was also mentioned on our clinical footnotes, and cautionary notes were given. It's likely to develop resistance during treatment if you start giving systemic antimicrobials. Then again, this is something that I already discussed very exhaustively about AMC-beta-lactamase. I won't go to the details over here. Then this is the case, again, same thing only. This is also an intravitreal cloacae. Now this is Salmonella typhi. This is the thing that I think previously also I discussed, that we stopped reporting ceftriaxone, we stopped reporting all the carbapenems, we stopped reporting, BLB-like combinations also. We just reported the 3 primary drugs, chloramphenicol, ampicillin, and cotrimoxazole, along with pfloxacin, nalidic acid, cipro, and azithromycin. So these are 7 drugs that we are doing the selective reporting. And then again, we also mentioned classically that Salmonella typhi and Salmonella and Shigella species are intrinsically resistant to aminoglycosides, tigecycline, first, second generation cephalosporin, cephamycins. So according to and as per CDC guidelines, we are doing the selective antimicrobial reporting, and then we gave the therapeutic index, and we suggested that ampicillin should be given as a in this particular dose. Ampicillin should be given 6 hourly, 1 to 2 week extended infusion for not less than 3 hours. So again, we are propagating the use of lower end antimicrobials based on the MIC reporting for Salmonella typhi, and not going for third generation cephalosporins. Now, what are the comments that you will send? That this is something that many of us would be encountering: carbapenem resistant, but third generation cephalosporin susceptible glucose nil fermenter or non-fermenter. So this is a very common thing, that a very common query that is often addressed. Many people ask me also. So this is the kind of comment that we send, that possible cause of carbapenem risk, because glucose nil fermenters are known for non-presence of beta-lactamases. Their mechanism of resistance is not primarily through beta-lactamases. They are primarily through efflux pumps, overexpressions, or OPRD suppression. So these are the kind of clinical footnotes that we can send in such cases. This is the two reports that we have sent. This is an unusual phenotype, but a common finding. Looks unusual, but it's very common. Lab error has been ruled out by repeat testing and quality control, because one might expect, how can it be the opposite? How come it is ceftaroline susceptible and imipenem, meropenem resistant, or maybe imipenem resistant? Meropenem still comes out to be susceptible at times, but imipenem normally comes out to be resistant. So we have mentioned that most likely this is the OPRD downregulation that decreases the periplasmic carbapenem, and the upregulation of efflux pump proteins that throw out the carbapenem specifically, and are likely mechanisms in this case, kindly correlate clinically. So this is one thing very baffling for many of the microbiologists. Why does this happen? So this is the reason why this happens. Now, this is a major challenge that is faced by many of the standalone labs. Again, I think some labs had, some people had asked this query in the previous sessions also: what do you have to say for the standalone labs, where there are many challenges they are facing. So first challenge, selective reporting is a major challenge with the rival labs who are reporting 36, 48 antimicrobials they're reporting. So that's a major issue, because we have to limit to our selective reporting. Then pressure of reporting some antimicrobial. You're reporting Staphylococcus epidermidis from urine, but at least give us some antimicrobial. You're reporting E. coli from stool, but at least give us some antimicrobial and antibiotics. So that is the kind of very stupid kind of demand from the clinicians that they have to succumb to at times, these standalone labs. Inaccessibility to patient details, far-fetched samples, like samples are coming from far away from the deep villages of Haryana, and they're going to big labs in Delhi somewhere, or Bombay, they are going somewhere. So you can't trace the patient. There's inaccessibility to patient details. And similarly, you cannot follow the patient treatment also. There's non-traceability to the patient. You are recommending some antibiotics, but you don't even know whether this patient is responding or not. Should I release a second set of antimicrobials or not? That also we don't know. Of course, the cost factor, you say it's a contamination, repeat the sample, then becomes the cost factor for transportation, for sampling, for manpower and everything. So as this very popular ad was there, 5 problems and 1 solution. So only the solution is that to one-to-one interaction with the clinician over the phone, email, WhatsApp by dedicated clinical microbiologists. Until you don't communicate, you don't talk, you don't speak, you don't convey your messages, these problems will keep on arising with all the standalone labs, because we are treating the patient. We are not treating the bug. We are treating the patient. So we just don't report the bug. We have to report to the patient. So talk to the clinician over the phone. If you don't discuss with them, then this issue will continue with all the standalone labs. This is a very common thing. And many of the enable assessors also, they raise NCs with standalone labs regarding these things, that why are you doing this? Because these are the kind of pressures that the standalone labs are often dealing with. Then, of course, for those who don't have data management softwares, there is no Predix. There's always WhoNet. You don't say that, no, I don't have data management software. WhoNet does wonders. It is like Jipper people are using a certain software, so that software is costly. So this is the poor version, the poor man's version of that software. It's absolutely free. You can WhoNet, you can use WhoNet, you can customize it according to your lab. You can you can convert it and make it any way that you want to. WhoNet also keeps on upgrading the CLSI breakpoints also. It also has got UKIS breakpoints also. You can customize the breakpoints also on WhoNet. If you don't have availability on, let's say, one particular thing, then you know that, okay, if FDA is available, then let me add the FDA breakpoints for that particular antibiotic. So even that can be done on WhoNet. So it's that customizable software. And you've got very nice, there's a 14 session long and each session is like 2 hours long. 14 sessions by John Sterling, who's taken the WHONET classes on YouTube. You can just Google it. There's a Ethiopia sessions. You can just Google Ethiopia sessions WHONET. So you'll get a set of 14 lectures by John Sterling, and he's the creator of the WHONET software, and they're absolutely amazing. So the take-home message I would say over here is that use the CLSI. Use this particular review which I had mentioned by Dr. Deepasri, Dr. Sandhya, and Dr. Purva. Very interesting review. They have also consolidated the CLSI footnotes. Or you can use this presentation also. This is I normally give it to who wants this particular presentation, and make your own footnotes. They are critical and they are accreditation requirements also. Now, if you see ISO 15189, you will see that you have to give some advisory services on your report. What is the clinical interpretation of your report? Like if you just imagine ultrasound report. This is the length of the gallbladder. This is the length of the liver, the posterior lobe, the lobe, and that's it. What is the clinical interpretation? Whether this is cholelithiasis is there or not, any biliary sludge is there or not. If that interpretation is not there, then that report is totally incomplete. Clinicians are very busy people. They are very simple people. They don't understand the complexities of the AST reporting. They cannot process too long a report. If you send a 7-page long report, okay, now I'm very enthusiastic, I'm very hyperactive, I'll send 20 pages of clinical report with so many comments, so everything they won't read. They cannot process too long a report. It's too much information for them to process. So they just want crisp things. So what you need to do is feed them with clear, lucid, simple, limited, relevant, and hard-hitting footnotes, if color and possible. So this you have to highlight. See, we all are doctors, and we have always highlighted our books with crayons and markers and highlighters, right? So send with highlighter. This is these two to be given. This is not to be done. So those kind of highlighting has to be done on the clinical footnotes. Use suggestive phrases like maybe, could be, is likely to be, not likely to be, rather than authoritative. Don't do this, do that. No, don't do that. Just must be, should be. These kind of phrases should be avoided always, because the responsibility falls on the clinician, because clinician will say, because you told me to do this, that's why I did this. No, I'm just suggesting you. It's your ultimately clinical decision is yours. So use suggestive phrases like instead of authoritative phrases. Communicate with them, like I said, to all the problems, there's only one solution. Communicate with them. Today only, we had a case of suspected CRE/hyperamcy producer, we don't know, from the urine of a 3-year-old child who had was operated for hypospadias. The patient was on catheter. We spoke to we didn't know what to do, whether to report or not to report. Then we called up the clinician. We spoke to her, ma'am, this is the case, what to do? So she said the patient is afebrile right now. The patient was given XYZ antimicrobial. The patient is afebrile. He's coming today. We'll evaluate him clinically. If he's febrile, if we did, then we'll send a repeat sample. When very good, send us a repeat sample, preferably clean midstream urine. And the presence of RBCs and pus cells will not guarantee that this is going to be a UTI, because the patient is catheterized. He's bound to have some pus cells or RBCs would be there. Patient is post-operative case of hypospadias. So we didn't report it. We just waited for the next sample to come. So once the next sample is there, then we'll do accordingly. So again, we have to learn to unlearn. We have to wipe the slate clean. We have to refresh our minds. We have to understand that we are not laboratorians. We are clinicians. We are clinical microbiologists. Our job is to give the clinical interpretation of the report. What does it mean? What to be given? What not to be given? The clinical microbiologist is the backbone of every antimicrobial stewardship program. And we are the ones who have to take the lead to control the AMR. With that, I'd like to stop over here. Thank you so much for your patient listening. I'll just stop sharing my screen.
Thank you, sir. Thank you so much. And yes, really enriching presentation, and I'm in awe of your capacity. You've been speaking continuously for
Your audio is cutting off, Dr. Neha.
So this is something, and as usual, question.
Hello, Dr. Neha. Can you switch off your video and continue on your audio?
Hello.
Yeah.
Okay. Better. Okay. So I want to request Dr. Reba if she, before we move on to the question and
Neha, you're not audible at all. Dr. Neha?
Dr.
Dr.
Reba,
Neha, your
ma'am.
voice is breaking up. I think Dr. Darshan, you can take over if you don't mind.
Yes, sir. Yes, sir. So, Dr. Reba, ma'am, if you would like to add anything to this session, ma'am.
Yeah, I think this talk was very exhaustive, Dr. Sumitra, and he has touched upon every aspect of the clinical footnotes, including the dosing and the outliers, which are very often there, which trouble us as clinical microbiologists. Like, for example, when you get a single isolate of especially now with the automation, you get all those tongue twisting names and of organisms, and then there's a single isolate. So what do you do with that? Do you report, or do you sit back and wonder what to do? So in such instances, he has given very good example, like whenever such things come, what we should do and how we should. My basic in my reporting time, my basic dictum was that when I get something which is unusual, which is not fitting in with the known pattern, I always ask for a repeat sample, because a repeat sample will definitely help you in, if that same organism is isolated, then you are 100% sure that this is the causative agent. So a repeat sample, request for a repeat sample is very important, in which case you need to at least pick up the phone and talk to the clinician. If you just send a report, please kindly repeat, then they're going to throw it into the dustbin. So you have to pick up the phone and or talk to the clinician that we need to get a second sample. The other thing is, when we get 2-3 types of mixed organisms, we normally hesitate to say the specimen is contaminated. So that is again another important point, which as clinical microbiologists we must remember, that the appropriateness of the sample is very important for us to interpret the result. If the sample is not appropriate, if it is contaminated, or if it is, then of course it becomes difficult. So that needs to be conveyed to the clinicians. Now, coming to the footnotes, of course, Dr. Sumit has very elaborately, discussed, and he also discussed an article which wherein they have taken the footnotes from the CLSI and have put it up as what can be used in the clinical laboratory. So CLSI should be our Bible, in the sense that every organism, every antibiotic susceptibility that we put up, we must look up the CLSI and see how best we can interpret the results. And finally, what he very importantly mentioned was that the language that we use, like instead of having a huge list of do's and don'ts, we need to pick out these the salient points which will actually impact the treatment, and the language should be very diplomatic language, like it may be done, it can be done. I'll tell you one personal example of mine. When in very early stages of my career, I had we have this urine culture in terms of semi-quantitative. So and having graduated from JIPMA, I thought nobody can question me. So I wrote, very significant growth of so and so. So the clinician, and it was in a private, corporate hospital. So the clinician came marching up and said, "Who are you to tell me it is very significant? I am the one who should be saying whether I am going to treat this patient or not." So that was my first encounter with the clinician. but then I learned very quickly, and somehow, so we have to be very, cautious in our approach, yet at the same time have a firm footing with the basic information and a backing of the CLSA. So that is something that we need to inculcate. And I fully agree 100% with what Dr. Sumit mentioned as the last part of his talk, was the problem faced by standalone labs. I quite empathize with the standalone lab clinical microbiologists, because they are up against a Herculean task of meeting the demands of the many clinicians who keep sending. And I know of many of my students who have been practicing, who are running standalone labs. The main problem is, when they actually send a sterile report, like there's no growth, the clinicians are very unhappy. They say, what is this you have written? There is no growth. So how can I charge my patient another extra buck for prescribing antibiotics? So this is again a very, very real picture. And I think as clinical microbiologists, we have to fight our way through and, try to, be very very methodical in your thing. And if you have a backing of the CLSI, or backing of a printed material to say that what you're doing is right, I think that should be very, very, that should be helpful. But yes, I do empathize with the standalone labs, but try and be as, what should I say, as, strict with your procedures, and as accommodative in terms of language with the footnotes. And footnotes is very important. Please remember, footnotes is very important. No lab report should go out of your, no report should go out of your lab without a footnote. So please ensure that these clinical footnotes, whatever it is, whatever, you have information, that has to be written down, and written down in a very succinct, clear, simple language, so that the clinicians, like Dr. Sumit said, if you write 3 pages of footnotes, they are not going to read any of that. So just be very specific and make sure that it is highlighted. So yeah, thank you, Dr. Sumit. It was a really, a very exhaustive footnote. Although we say footnote should be very small, but your talk was actually elaborated very much in detail, and it was very good. Thank you.
Yes, thank you so much, Reba ma'am, for again, highlighting the concluding messages so well. I will come to the question and answers, and let me quickly. So I'll take it in the order in which they were asked. So first questions first. So the first question is from Dr. Aditi Sondhi. She's from AFMC. She's requesting you to please include NDM organism recognition reporting treatment options in your next sessions. I would also like to know, sir, can we recognize and comment ESBA, LAMC, NDM, OXA, KPC producer on AST report? And the last thing, sir, can phosphomycin be given for Klebsiella in urine? And is it only given if nitrofurantoin is resistant?
I've actually answered this question. I was going through the question initially. I've answered, but still, for the sake of the audience, I'll tell you that detection of the phenotypic detection of these enzymes is a slightly tricky business. We have been doing it because it does not form a part of the routine AST protocols. So what you can do, the max you can, at the max you can do it, you can put it up as a second line, not, I would say, second line, second panel of testing. It's not primarily for AST testing. It is to detect the phenotypic, the cause of the resistance, basically. So there are numerous templates which are available, and there are multiple permutation combinations. I cannot explain it right now. It probably will take some few hours, or maybe 1 or 2 days of actual workshop to show you exactly how, what is an AMC producer, what is a hyper AMC producers, what are inducers, what are non-inducers, how can you detect, whether detect, this is a it's an MBL or a serine-based carbonamase. So these are also numerous methods that are available. So if, once we do a workshop at our place, maybe I can, you can always participate, and we'll show them. When it comes to phosphomycin specifically, CLSI mentions for UTI, lower UTI, for CRE, E. coli, and for Enterococcus fecalis, not for faecium. Only two places where the breakpoints are given. They are not given for Klebsiella. What we witnessed in our institute is that since we don't know the organism ID when you're putting it, so fosfomycin is there in our primary panel, but when we see Klebsiella, we don't report it. And besides, in any case, we see a very small zone diameter for Klebsiella also. So not for Klebsiella at all, definitely.
Can I just add one word here, Dr. Sumit? Yeah, you are very right in saying that your report should be primarily targeted towards the clinicians. So therefore, for them, whether it's an ESBL or AMC or NDM or OXAC KPC is not going to matter as far as the patient is their treatment is concerned, provided you have very carefully deleted out or removed these these susceptibilities from reporting, saying that these are resistant. So all you can say is that they are resistant. But for your own laboratories, archiving or data gathering, it is important, very important to know what is the pattern of antibiotic resistance that is prevalent in your area. So therefore, you must do it. But as far as reporting is concerned, you have to be selective.
Right, sure. Thank you. And we've got a lot of comments on, how can they view the previous sessions. So we have a video on demand link. I have been emailing all the, questions which are pertaining to that, the link. Plus, we'll also make sure that we post it on LinkedIn, plus send this with the Q&A, remaining Q&A that we share. So please access that link and you can view all the previous sessions on that link. The next question, again, a very basic one, but really important. What do we do if we get only one blood culture positive within 2 or 4 blood samples? And what do we do if we get 2 different organisms in right and left hand for blood culture? So this is from Dr. Banerjee from Ravindranath Tagore Institute of Cardiac Sciences.
If I were to do this, like for example, if you're saying you get only one blood culture positive, you've taken 4 blood samples, but you're getting only one blood culture positive. So that depends on the organism. If it is a coagulase negative staph, I wouldn't consider it as this thing. But if you're getting gram negative, definitely I'll consider that to be a pathogen.
Positive.
Then if you have 2 different organisms, then the dictum is that most of bloodstream infections, they are monobacterial infections. So the chances that either one of them could be a contaminant is very high. So you have to again judge which of them is likely to be a pathogen or which is likely to be a commensal/contaminant. Ma'am, you would like to add on that, ma'am?
I agree with you, but only thing one you have to remember, why did out of the 4 blood cultures only 1 come positive? Because you must remember that there is something called as transient bacteremia. So at the point of time when you have collected the blood, perhaps there was bacteremia, and then subsequent twice the bacteremia was there was no bacteremia. So that could be one of the possible reasons for this 1 sample becoming positive out of a couple of them.
Okay. The next point, guess, was covered to some extent in the session. Now, clinicians ask for therapeutic index calculated and reported in the report. Is it wise to give this information in the report? This is from Dr. Sumana from JSS Medical College.
That actually depends on whether if it is a blood culture, definitely the therapeutic indices, the concept of therapeutic index is more validated over there because we are looking at the serum MIC levels normally. Whenever you're doing the breakpoint evaluations on all those things, we are not checking for tissue-specific MICs. Now it will depend whether what kind of the specimen it is. If it is a specimen where let's say the size has been isolated from CSF, and if I know that the clindamycin has got a good therapeutic index, but we know that clindamycin penetration CS is very, very poor, so there is no point reporting it. So when it comes to blood, it is still much more easier. But when it comes to other specimens, you have to be very careful. So yes, it is wise to give therapeutic index if you have blood cultures, but otherwise you have to be more careful, and maybe you have to consult a pharmacologist over here, clinical pharmacologist, who are actually dealing with site-specific MICs actually. So that's another whole higher level of
New.
reporting.
Yeah. True.
Yeah.
Okay. So, next question: what should one do if a cancer of post-cancer its removal first urine culture sensitivity showed Klebsiella pneumoniae, resistant to all known oral antibiotics, susceptible to gentamicin? Patient received that for 10 days. Repeat urine culture sensitivity showed Morganella morganii 10 into 3 CFU resistant to gentamicin.
Uh,
I'm not sure
this
if
seems,
the question is
yeah,
clear.
actually,
Yeah.
send us this through the Excel file. I think we'll be able to
Yeah.
understand more if you
Yes.
don't start. No,
Yes.
there's some error in the question. We'll answer it. We send in
Yeah.
Excel file.
Yeah, a
Right.
little bit more
I
detail is required.
So, this is Dr. Archana. If you can further elaborate and clarify on this question through a follow-up comment, that can then get answered. So that will help us. Thank you. The next question. In the new version of CLSI, there are antibiotics for specific microbe recommendation. Is it recommended to be added at the footnotes?
Like for example, specifically for enterovectorales, this cefepime or for this SDD dosing is there. So if the MIC is so and so, then accordingly you have to change the dosing also, because the breakpoints are set according to the standard ATC TTD dosing criteria. Okay, so if you are increasing the, if you have a higher MIC you got, and for that MIC a higher dose has been validated, then that becomes your SDD. So in that case, if it is recommended, then you should add those doses and treatment options also.
Okay, Reba ma'am, anything from your end?
No, I agree with Dr. Sumit. Like that is the reason why we need to keep updating our CLSI guidelines. Because they come out with changes in every volume of theirs. So if we follow the 2 or 3 volumes behind, and then we keep on giving that, and then we find that the latest volume has changed that thing. So we should be, on top of it, and should be updating our recommendations and our reporting formats accordingly.
Okay, sure, ma'am. So, next, sometimes cytology report and microbiology gram stain report don't match. What's from Dr.
Yeah, this
Mamta
is
Bhatt, Utkal,
Mamta Bhatt.
Utkal
Yeah,
Hospital?
this very often happens because gram stain we actually do not we do a gram stain but not specifically look out for the cell types and the cell population, whereas cytology is specifically aimed at the cell population and cell types. What we look for in the gram stain is basically presence or absence of microorganisms, the bacteria or the microorganisms. So that definitely there is not going to be, there is going to be some discrepancy with the cytology, because gram stain we just say, pus cells seen, or plenty of pus cells, or we don't do any calculation like so many pus cells per high power field, etc. So definitely there will be discrepancy between the gram stain and the cytology report. So for cell count and cell morphology and presence or absence of cells, cytology report is very important. And as far as the organisms are concerned, to see whether there are any organisms or not, gram stain. So therefore, very often this discrepancy will be there. But that's not to be, you need not worry about that. You just have to focus on what organisms you see, microorganisms in the gram stain. And the cytology people will give the appropriate cell counts.
Sure. Thank you, ma'am. Anything, Dr. Sumit, from your side?
Thank you.
Okay, so is there any way of increasing diagnostic yield of CSF gram stain? Ideal centrifuging time. Dr. Pooja from Max Hospital. I think this is follow-up, ma'am, yeah, to your comment.
But actually what happens very often, the quantity of CSF is very minimal, in a small drop in a tube, which is not worthwhile centrifuging, because it's so minute quantity. So what we do in our lab is that we, of course, first we inoculate the sample, and then for gram stain, we do multiple layering of the CSF. So we put a loopful of the CSF, allow it to dry, then put another loopful, and then put a third loopful, so that it just layers. So the quantum of CSF that is deposited on the slide is a larger quantity, and we don't spread out the CSF. Remember, one important technique that you must remember when you are doing a CSF is, unless it's highly turbid, you do not spread it out over the slide. You just put a drop and then allow it to dry for some time, air dry. Put a second drop and then a third drop. So then you have a large quantity of CSF, and you will be able, after that you can do the gram stain, and you should be able to see that. So that's the practical way of increasing the yield. But if you have a larger quantity, then of course you can centrifuge it and take the centrifuge deposit and do a gram stain.
Sure. Thank you, ma'am. Next question from Dr. Madhurai from Hinduja, Mumbai. She wants to understand, how do we explain intermediate sensitivity?
If you want to explain it to the clinician, it is not going to be so simple. But if you were to understand on your own, intermediate sensitivity is, if you just broadly divide the resistance mechanisms into enzyme-based mechanisms and the target alteration mechanisms. The classical example of a target alteration mechanism is MRSA. So if you see in MRSA, there is no intermediate zone for cefoxitin. It is either yes or no. So whenever the target is altered, it is all gone. Nothing will work. But whenever it is a enzyme-based resistance process, then the enzymes are expressed depending on the variable expression of the genes. Now, if the gene is expressed to a higher level, there'll be more enzyme, there'll be more damage to the substrate. So as and when the enzyme expression gets increased, so it might go from susceptible to resistant with an intermediate zone in between. So that is where the intermediate the part lies, where you don't know whether the antibiotic will work in standard doses or not. It may work, it may not work, we don't know. But when we have validated it for a particular breakpoint MIC, for a particular dose regimen, then we call it a SDD. So that is what intermediate means. When the expression of the enzyme is variable, you don't know whether it is going to respond or not respond in vivo. Because what we are doing it is in vitro, it is a far away system as compared to a hyperdynamic in vivo system in the human body. So it's not a total replication. So at the best we can do is that even that's the reason why the 90-60 rule is there. Because in 90% time the susceptible will respond, but in 60% time even the resistant might respond. So that is the reason why, because the protein boundation may be less. There'll be maybe just around 20% protein bound, 80% antibiotic could be free. So there are multiple reasons. So just to keep that buffer zone, we keep it as intermediate. It may respond on multiple reasons. It could be bacterial resistance, or it could be the things like renal clearance, or multiple factors.
Right, sure. Thank you, sir. I have one comment from Dr. Pooja Gupta from Max. Sumit sir, she's appreciative of your efforts in compiling the Q&A. So compiled Q&A list prepared with the question asked at the end is very helpful for future reference, and I request you for the same for this session as well. Yes, Dr. Pooja, we'll be doing that. So all the questions which remain unanswered towards the end of the session, we'll be sharing comments of Dr. Sumit, and Dr. Reba ma'am will share this with you also to add the comments. So we'll do that. What comment should add to AST report when there is all drug resistance in a disk diffusion method and where automation is not available? This is from UAMCH, Mehfooza Nasreen. Dr. Mehfooza Nasreen.
I think I cited one of the examples where everything is coming as resistant. So in that case, again, following the 90-60 rule, again, for example, if it is NDM, if it is a proven NDM, now the enough evidence is there that you can go in for Cefta IV with Astronam, that you can do. But what happens if it is a pant regression pseudomonas, if it is in relation to everything? So in that case, you will ultimately have to rely on things like colistin dosing along with chloramphenicol in intravitreal, something like that. And like in one of the cases I mentioned, like you have a glucose nil fermenter, you are not able to identify it, even though it may appear susceptible on curvyball distribution, but then there are no breakpoint zones, because for nil fermenters, only breakpoint MICs are mentioned in CLSI. So in that case, the comment which I mentioned, that nothing is available, that we cannot interpret it right now, but unofficially you can talk to the clinician and then tell him that you can give this antibiotic. That's all we can do right now.
Okay, sure. Thank you. We have around 100 plus questions at this moment. So I've reached to the 22nd comment question up till now. So let's see, next maybe 15 minutes or so, we'll try to, see how much we can take, and then we can have the rest addressed over email. So the next question again from Dr. Madhu from Hinduja, Mumbai. She wants to know, how do we know if blood is contaminated for culture?
Ma'am, would you like to answer that?
Yeah, I mean, if you grow organisms, which are probably skin contaminants like the coagulase negative, etc., then definitely you can say that. Second thing is, you must also, like we have been harping on it from the beginning, that please go back to the patient and see if the patient is actually febrile or not, and if there are signs of bloodstream infection. So that is again, and if there are any catheters or intravenous lines, then that will help you to kind of choose, if you get a coagulase negative staph in a patient who has got a central line or a peripheral line, then you cannot straight away say that it is a, contaminant. Then if you get mixed growth of 2 or 3 types of organisms, that could you could straight away say that it is a contaminated sample. And if you get a very rare kind of a, organism which your automated system says this is so and so, you need to repeat the blood culture and see if you get the same isolate again, and then that is will prove that it is causing the infection. But otherwise, to say that sample is contaminated, it's fairly easy when you get mixed growth or commensals or 2 samples giving 2 different organisms. So that way you can make out whether it's contaminated or not. And if in doubt, always ask for a repeat sample.
Right. Yes, absolutely. Bang on, ma'am. The next question, what is the recommended volume of blood in neonates for automated or manual blood culture? This is from Dr. Kirti from UCMS.
As far as I can recall, it should be, ideally should not be less than 3 ml, but then for neonates, 3 ml is a huge amount. It's very difficult, but whatever that you can get, we used to get around 1 to 1.5 ml maximum for neonates, not more than that. But again, you have to have the right culture bottle for that. That's why we had separate blood culture bottles for pediatric blood culture bottles. They were different. Volume was different. So 3 ml is recommended. I would like you to go and refer to CLSI M47. That will give you the exact volumes.
So CLSI M47, what I remember, the current edition is recommending 1 to 4 ml volume. Bactec, BD Bactec pediatric bottles. So our recommendation is 1 to 3 ml, but volumes as low as even 0.5 ml have yielded good results. So yes, I think manufacturer's instructions, CLSI, all of this will help you arrive at this volume.
Yeah, because in a pediatric bottle, we can't go by the recommended volume. It would definitely depend on the child, on the neonate. So whatever volume you are able to garner, I think that should be taken in.
Okay, yes. Thank you. Ma'am, then what is the ideal time of reporting urine culture? Can we report no growth after overnight incubation? This is from Dr. Sagarika Pradhan from Chhattisgarh Institute of Medical Sciences.
Actually, if you normally you say, if you write, no growth, you have to make sure that the time actually at least there is an overnight incubation and a minimum of 18 hours has gone by, then you can say no growth in 24 hours. However, for you to generally say that there is absolutely no growth and the urine is negative, you can just by overnight incubation it may not be possible. However, most organisms which cause UTI are basically the organisms which grow overnight. So you should be able to make out whether there is growth or not.
Exactly.
So
I was
therefore,
about to answer that question with another question, that what is it that you're expecting in urine that will grow at 48 hours?
Yeah, exactly.
So there is nothing that you are expecting, like, some organism like
Fastidious.
maybe, yes, extremely fastidious growing in urine culture causing UTI.
So normally in our lab also we report it after overnight incubation. If there is no growth, we say no growth. Although sometimes the clinicians are a bit, skeptical. How did you say that there was no growth? Just now only we send the report. But however, send the sample. But however, if there is a proper, overnight incubation or a minimum period of 18 hours is over, you can straight away say that it is no growth.
Okay, thank you, ma'am. Again, so sir, there's another question on therapeutic index. I think you've addressed this, so I will, just skip this, move over to the next one. Can you explain more on common salvage of central line? More on commensal salvage of central line can be done if cons is isolated. I'm not very clear. Yeah.
Basically what they're trying to ask is that how do you salvage the central line if it is has got maybe a
Cons.
biofilm, cons biofilm is there, right? So this is a very common technique that was followed by clinicians in our pediatric hemato-oncology section. They use vancomycin antibiotic locks. So they used to make higher concentration antibiotic vancomycin solution, and then they used to allow a few ml to drip inside the in the lumen of the central line, and then they used to lock it. So during that entire time, that entire lumen used to be exposed to high concentration of vancomycin. Little bit used to keep on eluting from the into the bloodstream, but otherwise mostly it got locked, because you require the flow from outside to inside to go, because once you lock that flow, so that entire area gets locked by the high concentration of vancomycin. So vancomycin locks is one of the answers to this.
Okay, sure. Thank you, sir. Let me move to the next one. Many patients started on gram-negative cover for UTI. When such urine is cultured, we tend to isolate GPC, like enterococci in few numbers. Do we need to report them as pathogens? And do we need to do as from Dr. Suman from JSS Medical College again?
Ma'am, you like to take that?
Yeah, actually, if the patient is already on, has a gram-negative infection and is already on an antibiotic, and then you isolate just few enterococci. Remember, first of all, if it's a female patient, you can ignore it because it could be just, improperly collected or contaminant. And secondly, if it's less than minimal growth from the urine, and when the patient is already had a course of antibiotic, you need not kind of give any susceptibility for this or process it, because otherwise there will be no end to it. Because urine is not a sterile sample, as you all know. And so every little organism that comes out, that is grown in the urine, should not be taken into consideration unless you do the quantitative or semi-quantitative culture and reach a significant level of growth. Then only you can. Otherwise, it's no point in wasting time, money, and energy on doing just a few colonies of enterococci. So there is no need to do an AST or report.
So basically for UTI, you need to have pyuria, you need to have bacteriuria, and you need to have symptoms. Okay, most of three things. But in this case, pyuria will still be there because some remnant pyuria remains after treatment of UTI, right? That is one thing. Secondary, like ma'am said, GPC enterococcus, most likely it is going to be contaminant or from external genitalia only, and they have to go back and see what has been the transportation time and temperature, because that will really make a huge difference. Because you will say that, okay, GPC has been isolated, we saw pustules also, it's most likely a pathogen, let's process it. No, you have to check for the transportation time and temperature, and most likely it's going to be more than 2 hours, 3 hours of transportation or storage time. So that's most likely going to be a contaminant only, or non-significant, basically non-significant growth.
Okay, sure, sir. So, can sterile body fluids in blood culture bottles, sterile body fluid culture in blood culture bottles, can this be used? This is from
Already
Dr.
answered that.
Deepthi from HN Reliance. Yes,
You
so
already answered that in the, yeah.
yes, so even Bactec has we have mycolytic media which can culture sterile body fluids. So, okay, a lot of technical support with LIS is required for implementing a lot of these components. Probably, you know, when you were talking about HUNET, etc., this comment came in. A common issue we face is the availability of manpower and resources to implement this format of AMSP-based reporting across all labs. How do we overcome these challenges? Dr. Raksha from St. Martha's Hospital.
Yeah, I refer to her poster only. She's a very enthusiastic and a very, dynamic microbiologist. A very valid question that she's asked is about what we can do is that what the UK-based model is being doing. You have one technician or one person trained to read the breakpoint zones. Then the other person is sitting only on the HUNET and validating those reports, doing the selective reporting. So with just 2 or 3 people right now, also we just have 2 or 3 people only who are doing all these things. So that can be done. So you have to actually focus where you want to do the work. Like one small team of 2 people can do the work only on the reading, and 1 or 2 people can do only on the LIS or the HUNET. They can validate the report, do the selective reporting, copy paste the comments, and then dispatch the reports. So basically, you have to channelize the manpower in the right areas.
Okay, thank you,
Because
sir.
some of the softwares, they are as expensive as 7 to 10 lakhs. So like it's not possible for everybody to buy those softwares, because they will feed these comments in the softwares. They can just copy paste. You can just have drop down menus, but you can't. Even with those, they're very expensive software. So HUNET is one thing that you can also make your own comments on HUNET. With certain, you can add those comments on HUNET also.
Yes, I think both the options are there, and depending on the resources, they can choose as to what to go for to implement these. Yes, the next comment we got a appreciation from Dr. Nirupama Bondili, and thank you so much, Dr. Nirupama, for sharing this from Fernandez Hospital. She's writing, thanks to BD and the entire ASM team for conducting these sessions. They are very useful practically in day-to-day. Much, Dr. Sumit and Dr. Reba. Yes, the next question is from Dr. Benika Kajla from Fortis Hospital. She's writing, what is the drug of choice for pan-drug resistant Klebsiella on blood cultures?
Now, first thing that is you have to know was define what is pan-drug resistant. That is one thing, and then what is the resistance mechanism. Whether the resistance mechanism is enzyme-based, whether it is efflux mechanism, whether it is downregulation of OPRD, what is the resistance mechanism, depending on that. Even it is a carbapenem-resistant Klebsiella, in that case also you have to finalize whether it is a serine-based carbapenemase or a metallo-beta-lactamase. So once you're sure with that, only then you can say it. Because for serine carbapenemases, the treatment is going to be different. For MBLs, it's going to be different. For OPRD, it's going to be different. So first you have to decide what is the mechanism of resistance for that pan-drug resistance.
Yes, sure. So I have around 146 comments, questions. So they are, adding on, and it is already 6:30, and I can, only look at, especially Dr. Sumit, who's been speaking for to 2.5 hours. And also in the interest of time, so we'll compile all the questions, share with ma'am and Dr. Subit, with both of you. And we can then share it across with the participants. But thank you all, and a lot of appreciations as well. And these appreciations are what keep us going, give Dr. Sumit energy for speaking for 2.5 long hours. So please keep sharing your feedback, comments, which help us. So this is from SN Medical College, Agra. I'll just read out few. Dr. Vikas is writing, thanks to all of you for such. Dr. Archana from RRMCH, thank you so much, sir, for excellent and elaborate session. I'll have to run few more comments which are there, in between. But yes, thank you for making these sessions so interactive. And we will be there in touch with all of you, through LinkedIn, emails, to keep sharing the updates. And you can write back to us with questions, comments, whatever feedback that is there. Yes, one another comment. Excellent session from Dr. Mafuza Nasreen from UAMCH. So thank you, everyone. The audience, your appreciation, comments, questions, interactions, feedback, they give us energy to and motivation to keep going. And the need for these sessions is well reflected. Thank you for joining in today. And yes, thank you again, once again, to our speakers, facilitators, Dr. Sumit, Dr. Reba, for excellent session and technical content, which the participants are able to take back and implement in their practice. I would also like to thank my team, Dr. Arun, Dr. Darshan, who are behind the scenes, coordinating, so that this is seamless, as you see it today. So thank you. We look forward to see you in our next session. So we have two more sessions which are remaining in this 5-part series. We look forward to see you in the next session. So thank you for now. Thank you, everyone. See you soon.
Thank you.
Thank you.